Νομίζω είμαστε έτοιμοι να ξεκινήσουμε. Καλησπέρα σε όλους. Το όνομά μου είναι Γρήλης Στάθης. Είμαι από την εταιρεία Vent Dental που διοργανώνει το webinar σήμερα. Μαζί μου είναι η Χριστίνα Ιωαννίδη. Θα μας βοηθήσει και με το webinar και με τις ερωτήσεις στο τέλος. Εύχομαι όλοι να είστε καλά, να μην είχαμε προβλήματα με το χιονιά, τουλάχιστον στις περιοχές που επηρεάστηκαν από αυτόν. Ένα ωραίο βράδυ, κρύο, ωραίο βράδυ για webinar σήμερα. Οπότε θα ξεκινήσω με να σας ενημερώσω ότι αυτό το webinar θα γραφτεί, θα βιντεοσκοπηθεί και θα είναι διαθέσιμο και μετά το πέρας του στο YouTube της Vent Dental. Θα σας σταλεί φυσικά με email το link για να μπορέσετε να το παρακολουθήσετε και μετά. Επίσης, να σας πω δύο λόγια για τον ομιλητή που είναι σήμερα μαζί μας, για όσους δεν τον ξέρουν. Το όνομά του φυσικά είναι Miron. Να δούμε μερικά πράγματα που έχει καταφέρει. Έχει δημοσιεύσει πάνω από 300 άρθρα και κεφάλαια σε βιβλία οδοντιατρικά, ιατρικά και βιοηλικών. Με impact factor, μερικά από αυτά πραγματικά πολύ μεγάλο, πάνω από 20. Θεωρείται ένας από τους κορυφαίους νέους ερευνητές στην οδοντιατρική. Έχει βραβευτεί με το βραβείο του νεαρού ερευνητή.
Κάποιος γράφει, συγγνώμη, ότι δεν ακουγόμαστε. Δεν ξέρω αν θες να τσεκάρεις πάλι τον ήχο σου.
Ναι, αν κάποιος άλλος έχει πρόβλημα, παρακαλώ να το γράψει στο chat.
Θα σε ειδοποιήσω.
Ωραία, τέλεια. Έλεγα λοιπόν ότι ο Miron έχει βραβευτεί με 2 πολύ σημαντικά βραβεία νέου ερευνητή από το IADR. Είμαστε OK, πολύ ωραία. Προχωράω λοιπόν. Έχει στην περιοδολογία με το Sokransky Young Investigator της χρονιάς και με το IADR Implant Dentistry Young Investigator. Επίσης έχει λάβει και ένα πολύ σημαντικό βραβείο από το ITI, το Andres Schroeder Award. Υπάρχουν κάποια τεχνικά στοιχεία, εδώ μπορείτε να διαβάσετε όσον αφορά τις δημοσιεύσεις του και πόσες φορές έχουν χρησιμοποιηθεί έρευνές του σε άλλες έρευνες. Έχει γράψει 5 βιβλία. Όλα αυτά και τα 5 είναι στα top 3, στα 3 με τις μεγαλύτερες πωλήσεις της Quintessence κάθε χρόνο που κυκλοφόρησαν. Τα βιβλία αυτά είναι το Platelet Rich Fibrin, με τον Σουκρούν γραμμένο, το πρώτο του βιβλίο. Το δεύτερο είναι Next Generation Biomaterials, με τον Yufeng Zhang. Το Bone Augmentation in Implant Dentistry του Michael Picos. Φυσικά το PRF στο Facial Aesthetics. Είναι και ένα από τα θέματα που θα μας απασχολήσει κυρίως στο επόμενο webinar. Και το τελευταίο του βιβλίο, το Understanding Platelet Rich Fibrin, το οποίο έχει 50 συγγραφείς, πάνω από 50 συγγραφείς. Τέλος, να σας πω ότι υπάρχει και ένα ακόμα webinar στις 23 Φεβρουαρίου, 7 με 9. Τα βασικά του θέματα είναι το PRF στην αισθητική του προσώπου, το CPRF και το RPRF που είναι νέα πρωτόκολλα και καινούργια έρευνα που υπάρχει στο PRF και τη γνωρίζει ο Miron καλύτερα από όλους. Στο τέλος του σημερινού webinar θα συμμετέχετε και σε ένα poll, μια ερώτηση, για να διαμορφώσετε και το περιεχόμενο του δεύτερου αυτού webinar, ανάλογα με το τι θέλετε να ακούσετε περισσότερο. Για να γραφτείτε στο δεύτερο webinar, όσοι δεν το έχετε κάνει, μπορείτε να πάτε στο site της εταιρείας, στο www.ventdental.gr, να μπείτε στην ενότητα εκδηλώσεις και σεμινάρια και θα σας κατευθύνει από εκεί σε ένα link για να γραφτείτε και στο δεύτερο webinar. Νομίζω είμαστε απόλυτα έτοιμοι να καλωσορίσουμε τον Rick Miron. So, Rick, you want to join us?
Yep.
Okay.
Will do. I'll just get my screen shared here and get going.
I guess it was all Greek to you, right?
It was all Greek. Sounded beautiful. Okay, so thank you anyways for the introduction. It's a pleasure to be speaking to everybody in Greece right now. I know it's at nighttime there, so thank you all for joining. And I've heard that the conference will be recorded, so If you guys want to share it with some of your friends, etc., I'm more than happy to just share the info that we've done with respect to research on platelet-rich fibrin. So just a little background about myself. I'm Canadian, so I was born and raised in Canada. A lot of people know me for the work that we've done in Bern, Switzerland. So I was a PhD in the Department of Perio and Oral Surgery, where I spent 7 years living in Switzerland. And I'll kind of share my background knowledge of what we do and what I do on a day-to-day basis. In Bern, basically, my normal week is very different than most clinicians. I usually, on a normal before COVID, I work 2 days per week in private practice, and the rest of the time I do research. So I work in a research lab, and pretty much the role of my research team is to develop biomaterials and to do research with growth factors or with dental implants. So I'm very dental focused. Over the COVID period, of course, a lot of our research lab were closed. And so I've been working 4 or 5 days a week in private practice. But the majority of the stuff that I'm going to show you is work that we've done either in Bern or at my research facility in the United States. I always give a lot of credit to my mentors. So I'm sure for those that are dentists in the audience, you're familiar with either one of these gentlemen. Tony's done a lot of work with Emdogain. So we did a lot of work in growth factors since the year 2009. And with Danny Boozer's done a lot of work in implant dentistry, and he's the pioneer of guided bone regeneration. My story in 2009, I'd won a big scholarship to go anywhere in the world. So I interviewed at many universities, and the University of Bern is ranked #1 in the world for citations per paper and for research. So I wanted to go to Switzerland because I was doing work with dental implants. Nobel was relocated to Switzerland. Straumann is in Switzerland. All of the zirconia implants, they're actually all developed in our research facility in Switzerland. So it was a great place to work. And I did have the pleasure to work with these two gentlemen here. So they were more on the preclinical research side, and some of my mentors, so Dieter and Reinhardt. One's a histologist, the other one's a cell biologist. And so together we had a quite strong team, and our job as researchers was always to bring new biomaterials to the dental community. So on a day-to-day basis, and I'll show you examples of work that we do, a dental implant, for instance, before it's ever launched to private practice, probably 5 years before that, we get these dental implants. We test them with cells first, then we test them in animal models, and we did that at the University of Bern. Then guys like Danny Boozer or Tony Scullion did the first clinical studies, and then it gets launched to market sometime thereafter. So the cool thing about the work that we do and my job is we get to test a lot of these new biomaterials literally 3 to 5 years before anybody else gets to use them. We do a lot of the preclinical research, and then sometime later, they come to market. When I moved to United States, I set up my lab. So I moved back to Florida, and it's a great place to work. My parents and brother retired here, so I wanted to be closer to my family. And I basically do the same job that I've always done in Switzerland, where I just take new biomaterials or take new technologies, whether it be platelet-rich fibrin, which we'll discuss here. And our goal is to try and improve the technology, teach the technology to as many dentists or medical doctors as we can. And then from there, like I said, just keep advancing the field. So I do a lot of work, especially with platelet-rich fibrin, both in medicine and in dentistry. So I'll kind of go over where I work in a clinic and kind of the work that we do. The nice thing about platelet-rich fibrin is that it's not just utilized in dentistry, it's utilized in all fields of medicine. So the ability to have a lab like this one right here, this is my lab. We do a lot of work on optimizing PRF, how to build protocols that make sense, how to make PRF last longer. So we'll talk about what we call extended PRF that lasts 4 to 6 months. And I'll show data on, clinicians that we work very closely with, such as Michael Picos, who I know is Greek, and some of the work that he does, where in some cases he no longer uses collagen membranes, and he can use the extended PRF that will last 4 to 6 months in clinical practice. So we'll talk about that as well. The bulk of the work that I do was first published in 2019, so on biomaterials. And again, pretty much all allografts, or when we talk about BioOS as a Swiss company, we've done a lot of the development of their biomaterials over the years, and it was published in this book here. I was very shocked, actually. I wrote this book when I was 33 years old, and it was the #1 most sold book in the world in 2019. So in quintessence, like I said, it was a shock for Yufeng and I who had written the book, but we had spent about 15 years doing all of the research on biomaterials. And when we published the book, a lot of people were buying it and talking about how much it helped them in their clinical practice, because the reality is that there's really no reference textbook on biomaterials, how to use allografts, xenografts, what type of collagen membranes you should be using, why, what the difference between emdogain is versus PRF versus BMPs. I mean, there's a lot to know in dentistry on biomaterials, and there's never been a reference book. So that was the first book that we had published. And in the book, we do a lot of work with these new types of biomaterials that we bring to market. So an example of this one here, this is called tetranite, and it's a bone glue. And basically, it's an adhesive that's 100% biological, and it allows bone to glue together, or bone implants. And a lot of people around the world have probably never heard of this, but this is something, and this just goes to show you what we do. Since the year 2016, we've been working with some of these researchers, and what it is a group of researchers at Harvard and MIT were trying to figure out why certain underwater creatures, such as sandcastle worms or different underwater creatures, they can literally go to coral reefs or to rocks or to bridges, and they just stick for hours at a time. So the question is, why is it that some creatures underwater can go to an underwater bridge and just stay stuck and stay there for hours and hours at a time? Researchers were trying to figure out what proteins allow this glue-like properties that are found in nature, and they can stick for hours at a time. They isolated those proteins, and when they figured out what it was, they said, wow, ever cool, we now have basically an all-natural underwater glue. And they created what's called tetranite, basically a synthetic material that's a glue. And so what happens today is that if we have dental implants that are not stable, we can actually glue them with this tetranite material. So that's just a beta TCP mixture with, there's the glue from the underwater creatures. And again, this is 100% resorbable. It's 100% natural. It does not cause as much inflammation as one would expect. And when we make this stuff, we basically mix it together here. And over time, I'm just going to fast forward through this. It gets stickier and stickier. And then we're going to use it as an adhesive. Okay, so it's used in orthopedic surgery as well as in dentistry. So this is just an example of work that we do. This is 100% biological, 100% natural. And what you see in this video here is after a few seconds, it's already got glue-like properties. And it's got about 300 pounds of strength that's utilized right after it's been glued in about 5 to 10 minutes. So if you could imagine, somebody's going skiing and they break their femur. Years ago, we'd put, several pins in a plate and do all kinds of surgery with metal pieces. Today, we don't need to do that. Today, we use this 100% biological bone glue. We glue bones back together, and it's been used in humans now. We've had the opportunity, our research team with Dr. Picos, to do the preclinical work, and then he was the first clinician in the world to use it in private practice, which I'll show some of the cases that he's done. So on a day-to-day basis, this is from 2018. We developed clinical studies to get FDA clearance. This is an example of a dog study where these implants were placed in large defects. So I'll show you exactly how this was done. But we extract teeth in these animals, and there's 3 groups here. So we place native implants and native bone. So a regular 2.8 millimeter implant was placed in whole bone, and that's the ISQ values. And then purposely, we created these big holes. So these 4.3 millimeter holes, so big holes, you put a little 2.8 millimeter implant in there and it fails, obviously. But we did the same thing, a 4.3 millimeter hole with a little implant, 2.8 millimeters. But this one here, we added the tetranite. So that's the bone glue. And what you see actually in our studies is that throughout the entire study duration, the ISQ values stay high. You can load these implants right away. So think example clinically, you're extracting a molar, you want to place an implant immediately, but you can't get proper primary stability. We can add the bone glue, glue everything together, load them, it gets resorbed and replaced with bone, and it shortens the implant therapy time. So this is some of the preclinical work here. That's an implant right there. This is the black stuff here is the tetranite, that's bone. So it's very biocompatible, bone grows right up against it. And then by 32 weeks, this is after 16 weeks, you can see the materials being resorbed and replaced. You start getting bone implant contact. By 32 weeks, the bone is completely adjacent to the implant. The material is gone, it gets fully resorbed, and the implants stay integrated the whole time. So this material is a game changer in implant dentistry. This is Dr. Picos here, and he and I have worked very closely together over the last 5 years, and a great friend and colleague of mine. And I know he goes to Greek every once in a while and does courses. So if you get a chance to ever hear him lecture, he's got a lot of knowledge in the space. But this is the first case ever utilizing the tetranite. There's the implant. And this was a non-stable implant. That's the tetranite material that's been glued there. It was replaced over time, and it was loaded. This is a case that was done over 2 years ago. So we actually just recently published the first human cases with 2-year follow-up. And this is the type of work that we do on a routine basis. So the nice thing about, the field that I work in is we get to see all these new and exciting materials years before they're ever utilized or sold to other people. We do the first clinical testing, and then we publish the data and get them FDA cleared. Other work that we did in Switzerland especially was with Emdogain. So again, this is Tony Sculian, who's did a lot of the first human studies on Emdogain with Dieter. We've done a lot of work with Emdogain, developing the protocols, how to use it. One thing that our group did when we published the work in 2016, and this article is being rewritten right now for 25 years of enamel matrix derivative, it's pretty hard to believe that, growth factors, and when we talk about platelet-rich fibrin, growth factors have been utilized in dentistry and medicine for over 25 years now. And that's really the future of medicine, being able to take small proteins, bioactive proteins, and use them for regeneration. With Stroman in our group, we developed Osteogain. So this is a new formulation of Emdogain. I'm not going to go into too much detail, but when you see Osteogain come to the market in Europe, this was developed by my research team. So it was work that I did in my PhD, and that's Emdogain, and this is Osteogain. So it's a liquid formulation of enamel matrix proteins. That was all work that we did, and we started this in 2016. And 5 years later, like I said, it takes 5 to 7 years where we have these materials, we're testing them every day, and then they get brought to market thereafter. It's meant to be utilized with the bone graft, so it's very different than Emdogain. I'm not going to go through all the details, obviously, but there's been a lot of publications that have been written on that. With PRF, the way that we got involved with platelet-rich fibrin research about 10 years ago was just, it was a new and exciting field. And the one thing that I always say about platelet-rich fibrin technology is just the research that was done up into, recently in this space was, quite different than some of the other research that we had done. So what I mean by that is if you're working at the University of Bern and you're about to launch Osteogain or test a new dental implant, before these were ever sold to the market, we had done years and years and years of research, probably 15, 20, 30 publications on a topic. So if you go online on PubMed and you look up Osteogain, there's probably 15, 20, 30 publications on this before it's ever sold to one clinician. And that's the type of research we were used to doing. And at the University of Bern, being ranked #1 in the world, we put a lot of effort into trying to optimize these fields. When it came to platelet-rich fibrin, the one thing about it was that, and people say this, the research is a little bit all over the place, #1. #2, it's an entirely autologous system. So just like you can use a connective tissue graft, you can't really have the FDA or CE go in and regulate, how you're going to use a connective tissue graft. So if you wanted to take a connective tissue graft from your tuberosity, you're, as a clinician, you're free to do that. You can use it whatever way you want. And it's very hard to regulate people that are going to use autologous tissues. And you see very similar situation with PRP or PRF, where people just go out, they buy on eBay different centrifuges, they put whatever protocols they want to put. And unfortunately, it's a very important system to be able to optimize how many platelets you're going to have, how many leukocytes. Different protocols do different things. And quite honestly, 10 years ago, the field was not very research driven. And unfortunately, when you ask companies, which we were used to, we were used to asking a company like Stroman, can we get funding to do implant research? Well, of course, they know that if they sell one dental implant, you know, it might cost $200-300 US. There's a lot of money that's made in that field. So of course they like to fund this research and everything gets better. Unfortunately, in this field, and I always say the biggest problem with it is that when you buy PRF tubes, you know, they're about $1 or €1 each. And no company wants to invest money into this technology. And so it took a lot longer, you know, for the field to get better and better. And of course, our team in 2013 was when we published our first articles on this, have done a lot of work over the years to try and improve it over and over. And this first lecture specifically is going to address what is the best, most optimized way to actually concentrate, you know, platelet-rich fibrin. So I'm a cell biologist by training. You know, I've also studied perio, and, you know, we do a lot in the facial aesthetic field now, but I collaborate with a lot of doctors across, you know, all fields of medicine. But my main expertise is really in cell biology. So our group at the University of Bern, what we really focus on is how do we take blood, whole blood, how do we put it in one of these centrifuges? How do we separate these cell layers properly to concentrate them as effectively as possible? When you look at, you know, the ranking systems for expertise in platelet-rich fibrin, these are all independent groups that basically rank people based on publications, how often the papers are getting cited, who's contributing the most to the field. At the University of Bern, like I said, our school is ranked #1 in the world for periodontics, and we're ranked #1 in the world for platelet-rich fibrin therapy, because over the last about 7 years, all of the most cited papers in PRF technology are all coming from our group in Bern. And myself, like I said, I'm ranked #1. Yufeng Zhang is ranked #2, so he's also very highly ranked. And I'll show some of the research that he's done. He's done a lot of the development of tubes, so how important the tube technology is in platelet-rich fibrin, which I'm going to get into so you guys understand tubes a little bit better. Dr. Nelson Pinto, he's done a lot of great work, and we published with him as well, with Mark Karinen, who's in Belgium. They've done a lot of work in the medical space with wound healing, diabetic wound healing, these types of things. They worked as well with Dr. Castro, who's done a lot of great work. Shyam Ganatzi's done a lot of work with the APRF protocols, which were very popular in around the year 2015-16. He's got some really nice papers from 2014 that he did with Joseph Chakroun, who we've published with as well. So they're all obviously very respected colleagues as well. Misako's done a lot of the work with our group on how to separate these cells. So I'll talk about her work as well. And then Tony and some of the other people in our group that you see in yellow here have done some of the clinical work with our research team. So, you know, we are ranked #1 in the world for the work that we've done. And me specifically, like I said, what my research team has really contributed to the field is, how are we going to separate blood properly in a centrifuge? What are the protocols you should be using, and why, you know, certain things like using a horizontal centrifuge versus fixed angle is so important, and things that are a little bit neglected in the field. So we're going to talk about that today. I work out of 2 clinics. So my first clinic that I work out of is a dental practice. I work 2 days per week, and I only do perio. And in my practice, I only save teeth. So that's all that I do. And this isn't the Keracetic group that I work with. This is, it's called Lakewood Ranch Dental. And we work with 6 other dentists, and there's 2 periodontists and 4 GPs there. So we have a big practice. It's 14 ops. We have about 10,000 patients. We use the technology, the periodontists and I, for practically everything we do. So we have a lot of expertise in the perio field. The other 2 days per week, I work in Keracetic. So this is my actual office, and I own it. It's very different. It's not a dental practice at all. All of these other doctors are medical doctors, so everything we do is on the medical side. Dr. Robert Talek is an orthopedic surgeon, so he only does joint injections, spines, knees, shoulders, and so we do a lot of work with him, with PRF, with exosomes, with amnio fluids, a lot of things that are probably not available in Europe, but we always test the regenerative science. Dr. Jorge Gaviria is a plastic surgeon. So he and I do a lot of work in the facial aesthetic field, as well as he does a lot of body stuff. So body contouring, vaginal rejuvenation, this type of thing. And Dr. Karen Sutton is a women's health doctor and an endocrinologist. So she does a lot of IV type treatments where she does exosomes through IVs and other things. So It's nice because for me, I get to see what's going on in dentistry and I practice in that space. And then with these guys, it's more research driven. We're all affiliated with the university, so it's at Scripps, and we really try and push the field forward by testing new technologies with a lot of these doctors. Between all of us, they're all researchers as well. We've published over 600 articles and have written, I think it's 15 textbooks between all of us. So it's a very research driven clinic where we're trying to really push the field forward. And it's a lot of fun to work there as well. So when we talk about PRF, okay, very generally speaking, in whole blood, you have three major cell types. So there's platelets, there's white blood cells, and there's red blood cells. And as cell biologists, we've learned exactly what all of these different cells do. So we know that platelets, for instance, are responsible for regenerating tissues and helping with clotting, okay, and they're the smallest cells. White blood cells, they fight infection, obviously. They're also important for regeneration. So we'll talk about how important the immune system is as well. And then there's red blood cells which carry oxygen. So very simplistically, I always, when I actually consult with patients, I always tell them that the body is truly an amazing thing, right? So the body, I give an example of just very simply, if you're in the kitchen and you're sitting there cutting a cucumber and away you go, you're cutting a cucumber and all of a sudden you slice yourself, right? You cut yourself. It's pretty amazing to think that your body is going to actually heal itself all by itself, right? And if you're a cell biologist and you're actually studying pathways, there's a lot going on there with a lot of different cellular pathways, cell types, on and on and on. We're not going to get into that stuff there, but it's pretty amazing to think that all of a sudden your liquid blood is going to form a clot, right? And how does that happen? Well, your main proteins that induce clotting is fibrinogen and thrombin. And when they get exposed to oxygen or air, all of a sudden a clot's going to form, okay? Clot forms, then cells get trapped in the clot and growth factors get trapped in this clot, and then healing is going to happen. And that all happens, over the next 21 days, your whole body is going to heal itself. You didn't have to sit there with a laser and shine it and, look at it and say, okay, I need my body to clot now. I mean, your body is doing this all by itself naturally. And those are all your intrinsic wound healing properties. So I always tell people, the body itself is really an amazing thing and it's able to regenerate itself. And it's, the body is an amazing, amazing thing. But there are certain times when these defects get so big, or you have some kind of systemic condition where you can't heal yourself. And the classic example of that is, diabetes. When you have diabetes, you always have issues in your extremities, right? So if you take a diabetic person, when they have major problems, it's always related to extremities, typically diabetic foot, right? So the bottom of your feet, you're outside, you're playing tennis one day, you get a tiny little crack, which would normally heal, but in that person, they have diabetes. And in diabetic people, they don't have blood flow that's the same as normal people. And, your heart is way up here, your foot is way down there. And unfortunately for that person, they're not getting enough blood flow to that area. And for that reason, they don't heal. And so with Robert Marks, who's the pioneer of PRP technology, so he invented the whole concept and he works at the University of Miami, and a very close friend of mine and somebody that actually wrote the foreword of the new textbook on platelet-rich fibrin. He was one of the co-authors there. And what Dr. Marks used to say is, it's pretty amazing to think that you understand that it's a blood flow related issue. And so what he did was he said, well, if I know that that diabetic person is not healing because of blood flow, I'm going to collect some blood from this person. I'm going to spin it in a centrifuge on top of that and concentrate the cells that are important for wound healing. I'm going to then take the body's intrinsic ability to heal itself, take it to the defect at the bottom of that person's foot and allow healing to occur. And so that's what they started at the University of Miami. And he was also dealing with a lot of complex wounds in the oral cavity with respect to osteonecrosis of the jaw. So when these people have long-term use of bisphosphonates in dentistry, they started having all kinds of issues, bone was being exposed, low blood flow, on and on and on. And he took this technology and used it in the oral cavity. And, he's really somebody that is acknowledged, and some of his papers on PRP are very, very highly cited. So, he created this concept where we know that we have blood flow disorders. We know that as we age, blood flow goes down, right? As you get older and older, blood flow goes down, 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 down. And so we're going to take this technology where we're going to take blood, spin it, concentrate the cells, and then use them for regenerative purposes, okay? A lot of people in our practice are familiar with PRP, and they are not familiar necessarily with PRF, especially in our care aesthetic. So in the facial aesthetic world and in the orthopedic world, at least in the United States, many people know PRP. They've never heard of PRF. And I explain to patients this very, very simply, and I actually recommend you guys do it the exact same way, okay? What I tell patients is just, you know, I give them the example of cutting themselves with a cucumber. When you cut yourself in that cucumber, the first thing that needed to happen for you to heal was a clot needed to form, right? If that clot doesn't form and that person just keeps bleeding, 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 if they keep bleeding and no clots form, they actually never heal. So with PRP, what I tell people is that many years ago, when Bob Marks was doing this work, he had to use anticoagulants in the tubes because they didn't know the technology of how to build tubes and how to improve tubes. If you put blood in a tube, it would clot. And so they were building these protocols. They would always add anticoagulants into the tube, prevent clotting to occur. Then you could actually take this tube, put it in a centrifuge, separate the cells based on density, and then put it back into the patient. But the problem is that, let's say I have a pro athlete in our office and I'm going to do a knee injection, okay? If you do a knee injection to somebody, you get the benefit with PRP of having all the platelets and the leukocytes that are going to help with healing. But you also have this negative aspect that, you know, clotting is very important for healing and one of the first and most important steps, but you're actually putting inside that patient something that's going to prevent clotting to occur, right? And so the difference between PRP and PRF is just you remove all these anticoagulants, and now you have something that is completely chemical free, and it's actually going to clot upon injecting. And you know, clotting is very important for healing, okay? Excuse me. Now, how is that done? A lot of people ask that too, especially medical doctors. They say, how can you do all this work without having anticoagulants? How can you separate the cells? And we'll get into that in a little bit more detail. And the way that was done is you develop a tube that's very hydrophobic. So typically when you look at a dental implant, and we'll get into this in more detail later, you build hydrophilic surfaces that are very water loving, and clots will then form on hydrophilic surfaces because platelets are attracted to them. If you build a tube wall that's very hydrophobic, it's pushing platelets away from the tube wall where clotting happens, and it stays liquid longer. We'll get into more detail later. That's something that Yufeng Zhang's done a lot of work in China helping with the development of that. Okay, so those are the differences between the two. And like I said, we know that platelets are the light guys. They're relatively easy to separate with a centrifuge. White blood cells and red blood cells are very similar in size and weight, so they're a little bit trickier to separate, and we'll get into more detail on how to do that. Okay, so this is a figure from one of our first papers that we published on the effects of PRF for soft tissue healing. In these papers here, like I said, everybody that works with PRF knows that it's better for soft tissue. So in dentistry, we prefer it for soft tissue when healing over hard tissue. And we also know that in fields like facial aesthetics, for instance, it's great to use in that field because it is for soft tissue, and in facial aesthetics, it's all related to soft tissue. Okay, so in here, we have different growth factors all found at different levels and different cell types, and we're concentrating the platelets and leukocytes. In a standard membrane, the one thing that gets confusing is that there's different protocols where you can accumulate, you know, these platelets in different areas. We can evenly distribute them throughout the PRF membrane. We can concentrate them just at the buffy coat. We can do different things depending on our spin protocols. And that's one thing that clinicians are kind of unfamiliar with, and we're going to get into detail on how to do that properly. So generally speaking, whether you use PRP or PRF, you're going to accumulate these main growth factors. So one of them is VEGF, vascular endothelial growth factor, that's going to help with blood flow. PDGF, platelet-derived growth factor, so that's literally the growth factor from platelets. That's going to help recruit cells. And then TGF-beta is going to help these cells proliferate, okay? It's also very important to understand that, you know, when we have issues related to blood flow, so let's say, for example, I have a diabetic person. If I have a diabetic person, they have a blood flow disorder. This is a blood flow solution, right? So I prefer to use PRF in somebody that's a diabetic than a normal person because the diabetic person has blood flow related issues. So I expect to have better results in that diabetic person because they have a blood flow disorder. I'm going to help them out. Any tissue that's low blood flow, so for example, cartilage for knees, very avascular. So our orthopedic surgeon that does all these knee injections, you know, he loves PRF. Why? Because he's dealing on a day-to-day basis with low blood flow tissues. And so he's got a blood flow solution. He's going to inject that and he gets better results there. So very important to understand just, you know, what you're doing. And the reason why you can use things like PRP or PRF in practically all fields of medicine is that, you know, every single tissue that you want to regenerate can always benefit from having more blood flow. Okay. There's not a single tissue in the body that would not benefit from having more blood flow to that tissue during healing. And that's the reason why PRP or PRF is utilized in practically every single field of medicine today. So the goal of the centrifuge, of course, is to separate these cells based on their density. So we'll get into more detail in the research that we've done there. Of course, these are the people that we give a lot of credit to. And Professor Marks, like I said, is the real pioneer behind the entire field. Anitwa followed him very shortly thereafter with his PRGF, which is from Spain. And he did a lot of work in that space there too. And roughly 20 years ago, PRF was brought to market. And the first article was written by Joseph Chacroun. And the big concept here was don't spin with anticoagulants, right? So just if you want to get healing to occur better, and if you want to improve the healing, you remove these anticoagulants, and that's how you get better healing, okay? So the one thing with platelet-rich fibrin that's a little bit different than PRP is that when you have, you know, a tube and it's filled with anticoagulants, you can spin whatever you want to. Whenever you have no anticoagulants, especially in red tubes, which are hydrophobic, you have to draw the blood quickly. You got to get it in a centrifuge quickly, and you got to spin quickly. Okay. So there's a certain amount of time that you have, and we'll go into more detail on how this is done. But that's the only real disadvantage with PRF is that you have to be able to do this in your office. You have to be comfortable doing blood draws, which is not very hard to do, but you still need that education, and then be able to draw fast, get it in the centrifuge fast, spin fast, and then use it thereafter. Okay. And we'll talk about how that's done. So Misako Kobayashi, as I mentioned, she was somebody that did a lot of the early research on growth factors. And so in the year 2016, we published this article here looking at different spin protocols. So in our lab in Switzerland, you know, we were looking at different research that was done, whether it was done in Germany by Ganazzi or other people, Pinto, Kurinen. What we noticed was that when we looked at actual growth factor release over time, and we looked from 15 minutes up to 10 days, there was major differences in growth factors that were being released from the same person. We draw the same person's blood at the same time in the same tubes. Everything was the same machine. All we did was we would change the protocols, and all of a sudden we would get 4 times more growth factors that were released depending on the protocols we were utilizing. And that's when Misako would always say, you know, depending on how you spin has a great impact on how many growth factors are going to be released and how many cells you have left in these PRF membranes. So Misako would always say in our courses in Bern, Switzerland, you know, if you're a clinician and you're going to go through the trouble of drawing blood from a person, you're going to take out vials of blood, poke them with a needle, and do all these different things. It is entirely your responsibility as a clinician to make sure that you are spinning at the right protocols in order to optimize the wound healing properties for your patient, right? Why would you want to go through all this effort, stick a needle in your patient, do all these different things, and then spin out a protocol that had 5 times less growth factors in it? You know, it doesn't make any sense. And if you want to be a good clinician, you know, we always say in our practices, we always want to do what's best for our patients. Okay. And so, you know, it's really up to you as a clinician to be, you're not a technician that's just pushing a button on a machine and getting a PRF membrane. You know, you have to understand what you're doing. And as the research gets better and better, you know, you always want to do what's better for your patients. Okay. And we'll get into details there. Before I get into kind of the work that we do in dentistry, you know, I like to share some of these medical applications of use of PRF because I think that, you know, if you're a periodontist and you're saving 3-4 millimeters of clinical attachment levels or reducing pockets, you know, that's great. That's one thing. but when you can save people's limbs and, you know, do all kinds of great things in the medical field with the same technology, it's pretty impressive to see. And one thing that we did very differently in this, you know, the second book that I wrote on platelet-rich fibrin, which, you know, last year was actually the most sold textbook in dentistry in the whole world. What we did differently was we collaborated with a lot of medical doctors. We no longer have a PRF book for dentistry. I just said, let's write a PRF book for medicine and dentistry. So we have a lot of chapters that are dedicated to dentistry, and we have some chapters that are dedicated for medicine as well this time. And, you know, this is a exemplary case that actually I treated. So, you know, I don't do any kind of medical procedures by any means. Today, I work in an office with medical doctors. When I did this case here 2-3 years ago, of course, this was in a course actually that I did this. And this is actually one of my best friend's wife. You know, Natalie, amazingly, we live in Florida. And of course, there's a lot of skin cancers in Florida because the sun's so strong. And Natalie had developed a melanoma on her toe that was aggressive. And unfortunately for her, she's 41 years old. And the doctor said, we have to amputate your toe, you know, and she said, no, I don't want an amputation. You know, I'm 41 years old. I live in Florida. I'm in the sun all day. You know, can't we do something else? And he said, well, typically, if you had a melanoma like this, I could remove it if it was in your arm and put a skin graft over it, no problem. But the dermatologist, who was a surgical dermatologist, said to her, in this case here, I'd rather amputate. And the reason why is because that's on your baby toe, one of your baby toes on your right foot. And he said, that is the furthest place away from your heart. And if you think about this, the heart's on the left side of your body, way up here. The furthest place away from your heart is actually the bottom of your toe on the right-hand side. That's the furthest place away from your heart. And he said, the problem with a defect like that is that you're probably not going to get enough blood flow there. And I give it a 50-50 chance if I do a skin graft. And Natalie said, you know what? 50-50 chance. She said, I'm 41 years old. I'm fit. I don't take any meds. I work out every single day. Let's do the skin graft. So the dermatologist said, okay, sign the informed consents. They took out a piece of skin graft right from her arm. So she's got a skin graft there, took out a piece of skin, put it on the defect. 6 weeks later, went back in, and this is what they saw. And the dermatologist said, you know what? It didn't take. It's all infected. We need to amputate. And so when that happened, of course, my buddy Scott, who's not a medical doctor, he does not work in medicine. He knows what I do roughly, you know, knows that I do a lot of research in PRF world. And he called me. He's like, you know, Natalie's crying in the background, you know, big problem. She's got to have her toe amputated. I said, whoa, time out. And I could hear her crying in the back, you know, and he said, don't you do some of that blood flow stuff? The dermatologist kept saying blood flow, not enough blood flow. Don't you do blood flow stuff? And he sent me these photos, and I said, Scott, time out. I said, I only treat from, you know, the neck up. That's all I do. He's like, yeah, but you know, she's crying. She's got to have it amputated in 2 weeks. Why don't you just give it a go? Just try something. And I said, okay, well, I'll call one of my buddies, Dr. Pinto. I'll ask him what kind of protocols he uses for something like this. I can give it a go. And, you know, that's what I did. So in these cases here today, we make custom shape grafts, and we do this in dentistry as well, where today we know protocols where we can make whatever shapes we want. So I use these bioheat trays where we have different sizes, and I took a size that was relative to the defect. And on the back end of that, we always use a non-gauze stick pad. And that's, you know, from Dr. Pinto told me to do that. So, and he said, you have to do that because a normal gauze pad will attract moisture towards it. And you don't want to do that. You want to do the opposite. You want to push the moisture away into the defect. So I use a non-gauze stick pad. He said, tape it up, make sure it's very stable. So I did that. And then 1 week later, I removed this and it started healing. And when I saw this, you know, I couldn't believe it. You know, I just looked at that and I said, oh my God, you know, we've been using this technology for years in dentistry, et cetera. But in this case here, you know, it was the one for me that it kind of blew my mind, because I said, this was a defect. This was getting amputated. I applied 2 rounds of PRF on this defect and it healed it. And I did this about 3 years ago now, and it's still there. And every time I see her, you know, it's amazing to see this technology. And it was funny because, you know, after I did the second treatment, it was fully healed, and she had to go back to her dermatologist on a Tuesday morning, you know, in a surgery room to get it amputated. And when she showed up there, you know, I knew for sure the dermatologist was going to be like, what the heck did you do? You know, and I told Natalie, I said, she said, what am I going to say to the dermatologist? You know, what am I going to say to the dermatologist when I go in and, you know, he wants to do the amputation. He scheduled the whole morning to do surgery. I said, Natalie, tell your dermatologist one thing and one thing only. Tell her that your dentist did this procedure, right? And so, you know, he was, you know, kind of like shocked at what was going on, and it was funny. And he called me that day, and I knew he was going to call. He said, "What the heck did you do?" And you know, we trained him how to use the technology because he was obviously fascinated by it. And that same dermatologist now contributed 2 years later to our book chapter, and he's done many, many cases like this for wound healing. So it's really a great field to work in. One of the pioneers in this field is Dr. Castro Pinto, who's, you know, he works in Guatemala and Mexico and a couple other places. And, you know, they don't have a lot of money necessarily to use, you know, all the stuff that we use with growth factors and other things in other countries. But again, the body is an amazing thing and it has intrinsic wound healing properties. The problem is that in this diabetic person, there's not enough blood flow going to this defect. And if they don't heal, they can get infected. And when they get infected, it can be life-threatening. And so doctors typically will amputate something like this to make sure that there's no serious spread of infection. And, you know, years ago, Dr. Castro Pinto would get, you know, called up as this voodoo doctor to treat these types of defects. And they were thinking, you know, what a weird guy doing all this PRF stuff. And you know, I contact him because I see him every 6 months or so. He's treated something like 350 cases in a row that required amputations, and every single one of them he's been able to heal, 100% of them. Not a single amputation was required. And what does he do? He draws blood. Well, first of all, he makes custom shaped grafts, and I'll show a video of him doing this. So today, that's the BioHeat tray I was talking about, where we create whatever shapes we want. So these circular ones are more for medicine, for the diabetic ulcers, which always happen in circles. These are the ones that we use in dentistry. So I'll show cases of Dr. Picos using this stuff here to make membranes of custom shapes. These are for extraction sites. And whenever you understand the protocols, you know, you can allow this to clot. And now what you've created is your PRF membrane, the super clot with more platelets and leukocytes, whatever shape you want to make. And it's got more fibrin there. And we use this for regeneration. So we'll create these custom shaped grafts and take these to the defects. So what you're going to see here in a little video that I'm going to share with you guys is Dr. Castro Pinto. That's him right there. He's the person that's treated 350 or more of these cases in a row, and a little video of him right here. When they do these cases here, it's always done with the liquid PRF tubes. So we take it out as a liquid, not as a membrane. We add it to the custom shape. So he used a little bowl there. You can use whatever shapes you want to use. We have the trays now that we use, which are a little useful. And in cases like this, he'll inject around the periphery first with the liquid PRF. And after this is done, and you'll see when you look at this person that's a diabetic, you know, very white colored skin, not a lot of blood flow. That defect's been there for 2 years. Take the custom shaped graft, bring it to the area. Again, always use a non-gauze stick pad on that surface, and then healing will occur. Okay, so it's really a nice technology that's being utilized frequently in medicine. For those that have seen the copy of the new book, Understanding Platelet-Rich Fibrin, as I mentioned, I just got an email a couple of weeks ago, and you know, January 2nd or 3rd. I was really surprised. You know, this was a book that I'd written on my own, and Quintessence called me and said, you know, this is the most sold book again in 2021, which was, you know, real cool to see. And over COVID, what we did was we wrote the book entirely. It's very, very different than the first version of the book that we wrote in 2016. The book is, you know, instead of having this, for those that have the first copy of the little book, which is 200 pages or so, it's now a 400-page book. It's a big book, you know, full size. And what we did differently is, over the last 5 years, obviously, there was a lot more research that was done, but Quintessence launched a new technology, and they chose my book to launch the technology. And the technology was that, unlike any other book that was written by Quintessence before, this book has videos throughout the entire book. There's more than 65 videos. And what we did was, instead of showing people how to do sticky bone and show picture, 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 it now has little QR codes. And what you could do in the book is you take your phone, you scan over the QR code, and the video comes up of a video of me explaining how to make sticky bone or how to make these biografts here, how that's made. Or in the clinical chapters, how do we use PRF for sinus grafting? You scan over the video, you get a full 10, 12-minute video of Michael Picos doing sinus grafting with PRF, explaining step-by-step what he's doing and how that's done, or Howie Gluckman, a lot of our other co-editors in the book. So it was really, really nice. And we've gotten a lot of compliments on the book because not only do you have to read and look at pictures, people learn faster from videos. So it's basically like a whole course on platelet-rich fibrin that you get from a little from a textbook, which is really, really nice. And that's included in all of our BioPRF kits. So, you know, this is a video from the, QR code from the book. And all you need to do with your phone is you put it on picture. And whenever you just scan your phone over it, basically what happens is there's a little link that shows up for YouTube, and, you know, a video will come up on YouTube and you can watch it. So that's a nice, easy way for people to learn how to use these technologies. So in the book, this is just an example of a video. So this is chapter 10.5. This is making a biograft membrane.
Now, when you want to make a biograft, so what is a biograft? It's essentially a larger PRF membrane. And when we do this, we're going to use custom trays and we're going to make a biological graft essentially. Okay, so this is for medical doctors, for instance.
Okay, so in it, we show the exact protocols, exactly what you need, what type of tubes you need, what size needles you need, how it's done, how long you have to wait. And then in the video, you'll see here at the bottom, look, step 1, this is the centrifuge. Step 2, you're going to drop the liquid PRF. Okay, it goes step by step on how to do this, so that it's really nice for practices, because a lot of the times it's going to be your assistants that's doing a lot of this work here. And the nice thing is that, you know, the assistants can easily watch these videos, understand how to make sticky bone or membranes or whatever it may be, and they can get this all ready for you. So that was one thing that we added to the new book. Now, just to show people, you know, how far the technology's come, you know, this is the orthopedic surgeon that we work with. And, you know, our office, our Charisthetic office is a quite popular one in our area. So we treat a lot of movie stars and a lot of pro athletes come through our office frequently. So we're located in West Palm Beach, Jupiter, which is very, you know, rich area in Florida. And we specifically, Dr. Talek treats a lot of pro athletes. So we have pro athletes coming through our office all the time. And they like this more natural ability to treat some of these defects. And I want to talk about, you know, how far the field's come. So about 2 years ago, when we created the bioheat technology. So for those that don't know what that is, you can take plasma and you can heat it. And when you heat plasma, it denatures albumin and it changes the conformation, where PRF, for instance, will last 2-3 weeks and then it's gone, it gets fully resorbed. When you heat the plasma with our protocols, it will last 4 to 6 months. So we did all of the testing with FDA. It takes 4 to 6 months for it to resorb. And now you can use it for things like, you know, instead of using a collagen membrane that will last 2-3 months, you can use a heated PRF membrane that will last 3-4 months and use it the same way. Don't need to spend money on collagen anymore. You can make these membranes for $2 to $4 US. Okay, so it's very, very cheap. And when we created this technology, of course, guys like Dr. Talek was very excited about it, because he said, hey, if this really works, it'd be a lot better to use this for knee injections, for joint injections, for different things. And so, and we use it in facial aesthetics. So, you know, you can get some improvement in facial aesthetics when you inject liquid PRF. And there's been some studies that have been done. In fact, there's a Greek colleague, Dr. Nakopoulos, who's done a nice study using platelet-rich fibrin, just the standard PRF, for improvements of skin texture. And there's been other studies that have been done as well. The ability to heat the plasma and have this last for 4 to 6 months. Now we can start to think about replacing things like Juvederm and use a biological filler and, you know, actually augment tissue that's going to stay there for half a year, but it's 100% natural. And so this is something that we do frequently. We've been doing it for several years, where it's nice to combine this with liquid PRF and do different things. And of course, we've done a lot of, you know, research in that space as well. Our orthopedic surgeon probably has the most invasive use of this technology that I know on the planet. And so, you know, when we inject this into somebody's face, it's very, you know, mild. It's not really surgery. What he deals with as an orthopedic surgeon is that he's a spinal surgeon. And I teach courses with him. In fact, we have another one coming up in a couple of months, in 2 months. And I've seen him do this live many, many times. And when he does this, these patients have these types of tears in their spine, okay? And as one of the top orthopedic surgeons in the world, and he's the orthopedic surgeon for the US Olympic team. So he's in charge of, many, many things. He's a graduate of the Cleveland Clinic and Mayo Hospital. So he's very, very well trained. He's both MD, PhD. He's written many book chapters and many books and papers. He's very, very well known in what he does. And he and I collaborate a lot together because he's a biomaterial expert in orthopedic surgery, which is very similar to, dental bone medicine. So there's a lot of overlap there on biomaterials. And, he showed me this case one day and he said, this is a type of defect that's extremely painful for patients. And when I see patients that look like this and I see him treat these patients, it reminds me of somebody that needs a root canal. When you need a root canal, tiny little hole somewhere, there's fluid going back and forth into that nerve and it's causing all kinds of discomfort, right? And you see a patient, they're in extreme pain. When you actually look at these patients here that have the same type of issue, the issue here is that this larger hole is in their spine and their spine has a lot more nerves running up and down it. And when that person's just doing slight little movements or moving their back and there's compression of these discs, that fluid's going in and out of their back. And when it hits their nerves, they're in all kinds of pain. Every once in a while, you'll see somebody in our waiting room and they just get up ever so slightly and just a little bit of fluid goes to their nerve and they start screaming like, ah, and you can tell it's extremely painful. And so years ago, what he would do as an orthopedic surgeon and a spinal surgeon, he would take their spine, cut right down the middle of their back, open up, and he would use polymers. And with the piece of plastic, basically, the goal was to cover the hole, put some screws everywhere there, and obviously suture back up. He would use PRP to help with healing. And the goal was that if he can properly put that piece of plastic over the defect and cover it all and prevent any kind of fluid motion, then that person, maybe 6 to 9 months later, after a $100,000 procedure, these are very invasive, of course, could then walk again without any kind of pain or discomfort, so long as that would be perfectly covered, okay? That is extremely invasive. If you think about surgeries, this is about as invasive as you can get. You literally cut right down somebody's spine. You go in there, you put a piece of plastic with a bunch of screws everywhere. And unfortunately for Dr. Talik, when you do these types of surgeries, when they go south, when they go bad, you can paralyze somebody. And it's happened to him in his career. And of course, that's the worst thing in the world, right? These are very invasive procedures. You're playing the big leagues, big risk, big reward, so to speak. And you're always looking for less invasive ways to do this. So when platelet-rich fibrin, when he started learning more about PRF and it would clot, he said, wow, ever cool. I can then, inject maybe PRF in this defect. So if I could take a scan, figure out exactly what angle to enter into, I could inject PRF into this defect, wait for it to clot. And since the body has an ability to heal itself, maybe I could slowly close these defects and healing would occur. And that's what he started doing. But with PRF, of course, it's gone in 1 to 2 weeks. So he would schedule a patient like this every week, maybe for 6 to 8 weeks, and do an injection every week for 6 to 8 weeks. And on a scan, would look at the scan and slowly see this thing closing. And he said he could treat maybe 60% of his patients using this PRF technology by doing a series of injections. And he always said, this was a great, great, great technology because I could cut the amount of surgeries in half just by these injections. And if it didn't work, okay, fine. And 40% of the people, I tell them, you know what, it didn't work. We got to do surgery. And then you'd have to go risk the surgery and do all the surgery. But at least you could cut half the surgeries down. And so what you see on the previous slide is the title of the paper, Repair of an Annulus Fibrosis Tear of the Lumbar Intervertebral Disc using PRF. So that's the albumin gel that's been heated with PRF. And that will last 4 to 6 months. And the advantage of this was that, he would always say, if this is going to last 4 months, I only need to do 1 injection 1 time. And if it works and it stays there, I can do 1 injection and prevent surgery with one simple injection that I can do in a normal office, not even in a surgical room. And so this was titled a novel autologous technique that may prevent patients more extensive invasive surgeries. And so there's a little video of him. And again, this is found in our textbook. I'll go through it quickly here, where you draw the blood. So for those that have never actually seen the bioheat technology, when you heat the blood, it looks very different than your standard liquid PRF. So that's what it looks like after albumin's denatured. It's the same process when you heat eggs, for instance. You're cooking albumin or denaturing albumin. It's the same thing here. So we cook at a certain temperature in the bioheat technology. And this was, we started doing research with this back in 2019. Now, when you heat blood, the problem is all the growth factors are gone. Okay. If you cook things over 41 degrees Celsius, everything's dying. So what we designed was a lot of protocols where we would purposefully mix back in liquid PRF that you're used to from the Buffy coat. We mix that back in with the albumin gel. And this is a female-female lure lock that we use a lot in facial aesthetics. But anyways, we mix these products together. Okay. And what you get now is you're getting the albumin gel that's being coated with the liquid PRF. So now you have all the normal platelets and growth factors that you're used to that are infused into this albumin gel that's going to last 4 to 6 months. And that's what he's going to inject into the spine. And this is also what we also inject in facial aesthetics. And this is exactly what you'll see Dr. Picos used to make GBR membranes. And we do that a lot in Bern, Switzerland as well, over top of titanium. And so, it's a technology that's being utilized. And, for those that think, oh, is it safe? Can I use this? I mean, this has literally been injected into people's spines for years now. That's about the most invasive thing you can do with this, right? So when we use it in things like facial aesthetics or in dentistry, this is, there's no risk. I've personally done thousands and thousands of injections and thousands of cases in dentistry using this technology. It resorbs in about 4 months, 4 to 6 months. And it's a great technology because now I can go all natural. It's much more biocompatible. What you see here is Dr. Talek. So when he does these, this right here up here, this is an X-ray machine. And he developed a technique where he knows where this person's defect is, so where the hole is from the MRI scans. He's going to come in on an angle that he pre-calculates. And you hear him, he's saying X-ray, X-ray. So when he stops there, he's taking an X-ray. This is an X-ray. And he's got a screen up there. So as he's going in, he's taking X-rays, taking another X-ray. He takes about 10 X-rays to make sure that he's going in the right direction until he gets to the area that he wants. And then you'll see here, there's the needle. So it's in the area that he wants where the site is. Amazingly, this person is awake right now. And through the video, he's actually saying, are you okay? Are you okay? Do you feel pain? They have a lidocaine injection in the spine and a lidocaine injection right here. That's it. 2 lidocaine injections, they're awake, gets to the area, does the injection into the area that he wants to do. He has these patients in this position. So they're on a special table that they use in orthopedic surgery for spines where, they're down. The patient, after the injection is done, has to wait 15 minutes to make sure that it's going to clot in the area. Then he's going to remove the needle. Okay. The first time that I saw this, of course, I was blown away. I mean, I couldn't believe that this person's not going through surgery with the amount of pain that they were in. And after surgery, imagine you've just gone through a big spinal surgery and you get a little Band-Aid after the surgery. Okay, that's it.
Straighten your knee.
This is 15 minutes later.
No pain.
No.
Okay, the other leg. Perfect. Okay, and come back to me.
Okay, so it's pretty amazing. You've been doing that for 2 years, and like I said, we treat a lot of pro athletes in the office. And one day I remember we got this image here that was sent to Dr. Talek, who's our orthopedic surgeon, like I said, that works out of our office. And it was the cover of Golf Digest. And these 2 people here are pro golfers in the United States. For those that know anything about golf, this is actually the US gold medal winner. She won the US Olympics in Japan this year, first place. And 4 months before the Olympics, she could not walk. So golf is a very, very bad sport for people's spines because you're always like swinging like crazy and it's very bad for your back. He treats a lot of pro golfers. And of course, where we live in Florida, there's a lot of pro golfers that live in our area. And in her case, he did an injection with the BioHeat, the biofiller, that was heated. A month later, she could walk again, and she started training. And 3 months after that, she won the gold medal in the Olympics. And after she won the gold medal, she sent to Dr. Talek, dear Talek family, because his wife is the nurse that works with him. Both he and his wife work together. Dear Talek family, you're the PRF that holds us together. And I remember seeing this in Dr. Talek. Actually, I wasn't in the office or anything that day. And he sent me a text message. He said, look at this, Rick. Your technology on the BioHeat and all the work that you've done over all these years is one of the reasons why the US Olympic team just won a gold medal. You know, and it's something that, you know, we do. And of course, the field itself has helped a lot of people, and especially this technology now with the heated stuff. I'll show how that's used in dentistry as well. But to be able to, you know, really help people with spinal issues, with knee issues, and keep advancing the field, you know, is really a great service that we provide to a lot of people. And it's nice to see the research being utilized in actual patients. Okay. So before I get into, you know, spin protocols and everything, I just wanted to show, you know, how far the field's come and what we can do today. But it is a science, and there is a lot to understand in the field. And I always tell people, more important than centrifuges, whatever machine you're going to use, are the tubes. Okay. And we learned this kind of the hard way, and I'll explain kind of stories related to that. But when it comes to tubes, the way that the tubes works is very similar to, you know, biomaterials just in general. Okay. So the best example I can give is titanium implants. If you look at a dental implant, there's a lot of companies today that have hydrophilic implant surfaces. So if you look at SLA Active, or you look at Nobel Active, you know, they show these videos where they take a dental implant and they'll have some either water or blood, and they put it in, you know, a little bit of liquid, and you start to see the liquid or blood starting to rush up the implant surface. And they like to show these videos to show, look at how much blood is attracted to our implant surface, right? They show these nice little videos. Why is that so important? Well, the reason why is if you make a hydrophilic surface, it's very water loving, which means that blood's going to be attracted to that surface. If blood is attracted to the surface, platelets will actually bind to it faster, degranulate, a clot will form faster, growth factors are released faster, and theoretically you get faster osseointegration. So the more hydrophilic I make a titanium implant surface or a bone graft, the faster it's going to integrate. And it happens from clotting, because clotting is a very important step for healing. The same is true for these PRF tubes. If you make a titanium tube, an actual titanium tube, and that was done in Turkey, some of you guys may have read that surface. Titanium is a very hydrophilic surface. Blood will be more attracted to titanium. It will clot faster, okay? And it will make a better and bigger and stronger PRF clot, okay? The materials that people use more frequently, because titanium is very expensive, is glass. Glass is also a hydrophilic surface, and depending on how you process the glass, which is research that was done by Yufeng, you can make a very hydrophilic glass surface, which attracts platelets, clots formed. And so typically when we use the red tubes, they're made out of glass, or they can be made out of silica-coated plastic tubes, okay? We don't really like those tubes. Those are the ones that are sold by Intraspin. And of course, Intraspin's done a lot of work, and great clinicians that work in that space. But the only issue with that is that other scientists have found that some of the chemicals that are on the tubes, the way that they make them, these tubes, is they take plastic tubes and they basically spray coat glass on the inside of these tubes. And that will make it more hydrophilic. But the problem is some of those little glass beads that they're spray coating, so the silica will actually fall off, go into the membranes. You take that membrane out and you put it in a patient, you actually take some of the glass beads and putting it back into your patient, which is inflammatory, of course. So we typically don't like to use those tubes there. On the other end of that spectrum, we have hydrophobic tubes that are made purposefully as hydrophobic as possible. So when that platelet wants to go to the surface and make a clot, we make tubes that push the liquid away. And what happens is now the platelets are floating a lot around in liquid formulation longer. The more hydrophobic I make that tube, the more the platelets stay off the walls, the less likely they are to make a clot. So the more hydrophobic you make this surface, the longer it's going to stay liquid for. So some tubes will stay liquid for 15, 20 minutes. We've been able to make tubes that will stay liquid for an hour. And that might not be so important in dentistry, but when you work in fields like orthopedic surgery or in facial aesthetics, you know, when we do facial aesthetic treatments, the longer this stays liquid for, when we do injections and microneedling and hair injections and on, the better it is. And the way that we improve this is we make tubes that are more hydrophobic. And that was the research that Yufeng has done. And that's the reason why he's ranked number 2 in the world for technology related to platelet-rich fibrin. So he's done a lot of good papers on that. I do a lot of research with students as well, because I like to help them out early in their career. And, you know, we have science for programs. Of course, we have a lot of master's and PhD students, but I also even bring in high school students into our research facilities. And we do projects that are very, very easy, but just kind of get these young people excited about doing science and having careers in medicine or science. So this was Nick, and, you know, he wanted to become a doctor. So he's studying medicine, and I had a really easy project for him. And, you know, as we were learning more and more about PRF, we understood there's 3 things that improve or delay clotting, okay? Number 1, we already explained, the tube. The more hydrophilic I make a tube, the more water loving, the more it makes a clot. The more hydrophobic, the more it stays liquid. That's the first thing you can do. The second thing that you can do is that, just like our patient that was cutting themselves in the kitchen with cucumbers, the reason why a clot formed was because it was exposed to oxygen. So the oxygen will help the clotting happen. Same thing. If you have a red tube and you pop the lid and you leave it exposed to oxygen, it clots a little bit faster. On the liquid PRF side, if you work in facial aesthetics or orthopedic surgery, you do not want to expose this to oxygen, because you do not want this to clot faster. So we try and stay away from oxygen on this side and improve oxygen on this side. So that's the second thing you can do. The third thing that you can do, which we learned in the year 2019, 2020, is with respect to cooling. So we understood that when you convert fibrinogen plus thrombin to fibrin, okay, that's the conversion that happens to make fibrin, it's an enzymatic process. And enzymes don't work so well at cold temperatures. So when you get to colder temperatures, these enzymes, they don't work as efficiently. And so if we took a tube of blood and we just put it in a little cooling device, which is very, very cheap, it will actually slow down how much clotting will occur. And so in our field in facial aesthetics, when we take out the tubes, we literally just take the tube, put it in a little cooling device. It's called a BioCool. It's $89 US. It's very cheap. And we can delay the clotting. And we have an ability to have liquid PRF stay liquid, whereas 5 years ago, it was 15, 20 minutes and things would clot. Now it's 3-4 hours. Okay. So now in 3-4 hours, we can do pretty much any procedure in dentistry or medicine. So it's, you know, it was technology that was invented over the years. And with Nick, what Nick did was he looked at 2 types of tubes. So a hydrophilic one and 2 types of hydrophilic versus more hydrophobic, and then also in the cooling device. And so this is the little BioCool device here. You take the tubes, you just put it in this little cooling cup, and that will dramatically extend how long you have. So we had white tubes and blue tubes. The blue tubes were more hydrophobic, so they stay liquid a little bit longer, as you see here. But the biggest difference, not the tubes, it was just cooling it. So when you took those tubes, whether they be white tubes or blue tubes, and you put them in the cooling device, it would stay liquid for 3-4 hours. Okay, so it was a nice little addition that people can use. And at the other end of that spectrum, you could actually improve clotting if you got closer and closer to body temperature. So the body is at 37 degrees Celsius. And if you want to make a really strong fibrin clot, you can actually, you know, heat things up a little bit. Okay. So when we started heating things up and we did this research with custom blocks, what you can do in these cases here is, you know, we do a lot of digital technology and 3D printing now, but a lot of people were 3D printing guides for implant. At the same time, you could 3D print exactly the augmentation you want to do for bone augmentation. So we would, you know, plan this guide. And at the same time, we'd say, okay, we want to augment this much bone in yellow here. We'd build a custom jigsaw, which looks like this. One of them is the ridge. The other one is how much we want to augment. And basically what we would do is put the bone graft in there, close them up, take this, put it in an incubator at 37 degrees Celsius, because that's the temperature that a fibrin clot is going to form the best, okay, at 37 C. When we're done with this, what we've done, this is the custom augmentation we wanted to do. After it's been heated for 10 minutes, you can literally take this thing out and now you got your sticky bone, but you can almost bang it on a table. Okay, it's nice and clotted. Then we bring it to the defect, and instead of having to play around with sticky bone and try and shape everything, and this is a 2-second job. Raise flaps, clean everything up, okay, and take the custom shaped bone block basically, but it's all particles, put it on there and suture it closed, and we can shape it so that it stays very stable. And then we do periosteal and suturing, and it's a nice way to go in those types of surgeries. So you can do a lot of different things in the space, and there's been a lot of technology and improvements here. So in dentistry, like I said, there's a lot of things you can do. And again, this is a figure from the first version of our textbook here. There's membranes, there's liquid PRF, we can coat biomaterials, we can make sticky bone. I think for the most part, a lot of people, are familiar with the technology by now. So of course we use these hydrophobic tubes, the red top tubes, to make membranes, and we remove the lids for 5 minutes, we oxygenate them. And this has been taught by a lot of people. And then we use the PRF membranes for regenerative purposes. Now, always remember that on a full PRF membrane, the portion that has the most growth factors is always at the bottom, right, of these membranes. Okay, so that's going to be at the bottom. So we always want to make sure that, like, I don't like to see people that take out a full-size membrane and then they cut like the bottom 1/4 of the membrane because they don't want to have any red blood cells there. When I see people do that, I say, completely crazy, because that bottom portion is the portion near the Buffy coat, is what it's called, that has the most cells and growth factors. And we'll go through the data here just so people understand that a little bit better. So then you can do many things with this. Of course, you can make the plugs, you can make membranes. I'm not going to share these videos. These are all found on YouTube. So if anybody ever wants to find these, you can go to PRF EDU and then type sticky bone or PRF EDU membranes, whatever. The videos are all, we post them all online just to be able to help people. The only one that I want to share, of course, when you draw the liquid PRF, right? In these cases here, I do not want to pop the lid, right? I don't want to oxygenate this, because if I oxygenate the liquid PRF, it's going to clot faster. And if I want this to stay liquid for as long as possible, I try not to have any liquid PRF here. Okay, so I draw it up typically through the lids, and then we can then use it for liquid purposes. Do is we grab 2 of these membranes. Okay, when it comes to sticky bone, same thing here, and these videos are all explained online. But generally speaking, we start by cutting up 2 PRF clots, and the reason why we do that is because when we add the biomaterial afterwards, so in this case here an allograft, the bone allograft, when we add the liquid PRF afterwards, it'll form a sticky bone literally 10 times more together. Okay, and that research was done by Yufeng and published as well. So if you just add liquid PRF to a bone graft, it'll only clot so much, and it will only be so strong. It will only have so much sticky consistency. When you actually cut up 1 or 2 membranes ahead of time and then add the liquid PRF thereafter, you'll get a much better sticky consistency. So that's what you see here in this video. And then after this is done and this is mixed up, the liquid PRF is added. And that's how you're going to make a sticky bone with this type of consistency. Okay, so things that'll improve and have a nice sticky bone: number 1, cut up a couple PRF membranes ahead of time. And then number 2, if your bone graft has collagen inside of it, such as an allograft, which we use a lot of in the United States, it'll form a better sticky bone than, for example, BioOS, which doesn't have any collagen inside of it, or some synthetic materials. Okay, so, and that's what we like to use in dentistry, and we'll go through indications of what we use this for. Now, the work that was done in 2014 by Dr. Ganazzi in Germany was, a very, very nice paper that was done 7 years ago. And what he found and really showed very nicely in some of his histological studies was that when you spin, always remember that as you're spinning fast, the cells are going outwards and downwards. So if I spin for too long, for too fast, I'm pushing things down and down, so outwards and downwards. And unfortunately, what he had discovered was that the majority of the cells were actually found at the bottom of the tubes in the original LPRF protocols. And that's when he did a lot of work to slow the speeds down and slow the time down in order to get more of the cells in the upper layer. And he called that PRF. So many years ago, that was 2014 when he published that first paper. And probably from 2014 to 2018-ish, that was, the most optimized way that we knew how to actually spin PRF back then. And so this study here was a really good one that was done. We had done some work just looking at the growth factors. That's a photo of Misako right there. She was a Japanese scholar. She was both an oral maxillofacial surgeon and a PhD in molecular and cell biology as well. So she was a great person to have in the lab. And she would bounce back and forth between clinics doing oral surgery and doing research. And she found precisely what, his protocols had shown, was that you got a lot more growth factors released because there was a lot more cells. And between those years, that was work that, we had contributed to that field as well. And the first version of our book with Dr. Shakrun here, we always made the point that if you spin fast, you will get a bigger membrane, but don't be fooled, because just because you have a big membrane doesn't mean you have a good membrane. And so one of the figures from our first book was that you spin fast like this, you get a big membrane, but when you look at the amount of cells, few growth factors. And that's when, by slowing the speed down and slowing the speed and time down, you would get more cells and then more growth factors released. And because the technology was so cheap, to get an extra 1 or 2 tubes, like, I'd much rather be mixing with the bone graft 2 of these guys that each have 4 or 5 times more cells, as opposed to 1 of these guys, which, doesn't have that many cells inside of it. So most of us had adapted protocols. And if you do have a fixed angled centrifuge, which we'll get into, the protocols that were designed back then are still relevant today. And this work was, the first big leap towards more people doing research and better understanding how to separate cells based on their density. This was a slide that I got from one of my colleagues that lectures a lot. Her name is Dr. Delia Tuttle, and she put this slide together on just when she lectures, she was just explaining what was done over the years and how the field of PRF was improved over which year. And I asked her for the slide and if I could use it. So I'd like to give her credit because she put this together. But it explains, what was done over the years when PRP was invented. This is now anticoagulant removal. There was a period of 10 years where nothing was changed in the PRF technology. More research was done, slow the speed down, but then the time was higher, then slow the speed and time down. And by keep slowing things down further and further, all of a sudden we realized that if we spin for even slower for less time, it would stay liquid. And then the cool thing was, oh my God, it stayed liquid before it clots. We can draw this up, use it as an injectable, and then modify the tubes to make them more hydrophobic, to be able to have it liquid even longer. And in the year 2019, that was our research team that had shown, in a series of papers, that if you spun with a horizontal centrifuge, which we'll get into, that would be a much more effective way to concentrate these cells. And since then, like I said, this paper that we published in 2019, it's the most cited research paper in PRP or PRF world over the last 3 years. And it's one of the reasons why in 2020, that was the year that I was ranked #1 in the world for research. And a lot of it had to do with this paper that we published in 2019 here. So before we get into how to separate these cells properly based on their density, it's important to understand, because some people will work with PRF and they'll say, well, I'm getting a big membrane this time, a small one, this one, that one. And people couldn't understand why there was variability in the field, right? So obviously, when you're using this technology, it's very different than using Emdogain or recombinant human PDGF or something that you can buy off a shelf, because if I make it from a shelf, I can make it the same way every single time. But when I make platelet-rich fibrin, this person might be this way, this person might be that way, and there might be a lot of variability. So this study here, what we did with another one of our students, we looked at the effect of age, gender, and time between when we do blood draw and when we start the centrifugation cycle on what happens to platelet-rich fibrin. And so what I did was I told Anika, I said, Anika, come to some of my courses, and what we're going to do, I'm going to set up 6 centrifuges, the exact same centrifuge at the back of the room. And I'm going to draw 6 tubes of blood. And when I draw, you're going to record every person's age, their gender, if they smoke, where they live, get as much info as you can on every person. I'm going to draw the first tube. I'm going to run to the first machine, put it in right away, start spinning at 0 seconds. I'm going to draw the second tube, wait 30 seconds, and then spin. The third tube, wait 60 seconds, then spin. Fourth tube, 90 seconds, 120 seconds. Because a lot of people were saying, you know, how long do you have between when you draw the blood and get it in the machine and then start spinning? Okay, so what we found, which was quite interesting, when we spun, especially in red tubes, was that by 90 seconds, these membranes were already 13% smaller. By 120 seconds, so 2 minutes, the membranes were 23% smaller and had 50% the amount of cells. Okay, so what happens? If I draw a tube of blood and I just let it sit there for 2 minutes, while it's sitting there for 2 minutes, if it's a red tube especially, which is hydrophilic, which is meant to induce clotting, it's going to make so that some fibrinogen and thrombin is going to slowly start to turn into fibrin in this tube. And the longer it sits there, the more fibrin is going to be formed. And after 2 minutes, when I take that tube and I put it in a centrifuge, and then the role of the centrifuge is to separate these cells based on density, guess what happens? These cells that are trying to separate can no longer separate. They're getting trapped and they're not going to the right layers anymore. And we found about half the cells in those membranes, basically, that you waited 2 minutes. 2 minutes was too long. So we always tell people, you got 90 seconds to draw PRF tubes, okay? And when we say that, always remember as well that it takes about 15 seconds to fill a tube. So let's say, you know, I'm going to go into surgery and I'm going to draw 6 tubes. I draw my first tube, it takes 15 seconds to fill, I put it there. I draw my second tubes, another 15 seconds. Now 30 seconds has gone by. Third tube, fourth tube, fifth tube, sixth tube. By the time I've drawn 6 tubes, 90 seconds has gone by, right? 6 times 15 seconds. So I always tell people the most you can draw red tubes, 6 tubes. That's the absolute most you can draw. By the time you get to 7, 8, 9, 10 tubes, what happens? That first tube's been sitting there for 2 minutes or longer. And when you spin and you then take out your PRF membranes, you're going to see the following: full-size membrane, and then all of a sudden some of these membranes are getting smaller and they're not consistent. And the reason why is because you took too long to get this in the machine and start drawing. Okay, so blood draw should always be done in 90 seconds or less. Who makes bigger membranes, males or females? So there's also variability here. Who makes bigger membranes? Always females. And the reason why is that when you actually look at the hematocrit levels, a men has higher hematocrit than females do. So men have thicker blood, which means that if I have thicker blood and I apply a certain G force to that blood to separate these cells based on their density, the men will separate nicely. It'll be trickier to separate the men's blood because it's thicker blood, so you get a smaller membrane. A female has less dense blood, it's less thick, the membranes will be a little bit bigger, okay? How much bigger? On average, 17%. Okay, so in a perfect world, actually, you'd probably build protocols for females, for males, for old people, young people. But of course, in dentistry or medicine, you know, there's a lot of things to learn, and people just like, you know, the go buttons where they just push a protocol and start spinning. But when you do that, you're going to have different size membranes. And this paper kind of explains why that happens. So same thing in old people, as you age, hematocrit goes down. So you're going to have bigger membranes. Okay, who makes the biggest membranes? Old females. Who makes the smallest membranes? Young males. Okay, and you can change protocols if you want. It's something that we teach in courses just to understand this better. But the most important thing in that whole article, blood draws 90 seconds or less. Okay, so again, that's the most. By 2 minutes, you've already lost half your cells. That's too long. Okay. Now, we've done a lot of research as well over the years. This was back in 2018. We did this research. The one thing that I see clinicians make the biggest mistake in is not understanding the difference between RPM and RCF, okay? And to explain this very easily, you know, I like to always use the same example. Let's say, for example, I was holding a little child, okay? So let's say I have a 2-year-old and I'm gonna start spinning the 2-year-old around in a circle just so he has some fun. If I take the 2-year-old and I hold him here, and then all of a sudden I start spinning 1 rotation per second, okay? That kid will have fun. I'm spinning 1 rotation per second, away we go, we're having a lot of fun together. Okay, that's a 1 RP, S, 1 rotation per second protocol. If I hold that same child, but now all of a sudden I got him on a really long string. Let's say I'm holding him way out there on a long string that's 10 meters long, and all of a sudden I'm rotating him, like this, and he's still going 1 rotation per second. Well, if he's way out there and he's flying around at 1 rotation per second, that could be terrifying for that little child, that little 2-year-old. He's going around spinning at much, much greater speeds. And the G-force that he's receiving way out there versus in here is totally, totally different. But in both protocols, I'm spinning at 1 RPM rate, 1 rotation per second here, and I'm spinning at 1 rotation per second way out there. But he's going way faster way out there, and there's way more G-force way out there. So when you read a paper and it says, in order to do the APRF protocol, we spun at 1300 RPM for 8 minutes. That's specific to one machine and one machine only, okay? It doesn't mean that you can't use another machine. It just means that if the machine is, bigger, I might have to slow the speed down to get to the exact same G-force, okay? So when people report RPMs, it means absolutely nothing, because that RPM value is only for one machine at one angulation and one machine only. It cannot be used in another machine. If you use another machine, you have to recalculate the G-forces, the RCF values, okay? And you have to redo the experiments and re-understand where the cells are going, and on and on and on. So it's not so simple as people may think. And, in the United States where I live, I don't really care which machines you use, whether it's a Salvin or dual quattro or intraspin, it doesn't really matter to me. But do not use the same protocol from one machine on another one and another one, because it has to be modified. And in the year 2018, that's what we did. We took these different centrifuges and we optimized the protocol so that no matter which machine you used, you could get the right G-force and the cells going in the right layers. Okay, so that was work that we did back then. And I did this work with Yufeng there. That's one of his labs there, Yufeng and myself, where, we have our textbook there at the front of our lab. And, the G-force, like I said, on these different machines, whether it be the intraspin Chacrun's machine or the Salvin machine, it doesn't mean that you can't make proper PRF in any of these machines. It just means that you got to calibrate it. You got to understand what is the, the R value. So the radius at the min versus the max versus at the clot. What is the angulations? And this was all done with engineers to calculate all this and then figure out what the G-force, where we should be. And then it has to be verified in an actual cell biology experiment, which is what we did for these 3 machines in the study. And one thing that we learned, which was very important in the study, was that the actual tubes mattered more than the centrifuge. So I always tell people, you can give me any machine in the world and I can calibrate it and optimize it. Okay. Of course, I'd want it to be horizontal ideally, but I can always optimize, and make things better on any machine. But you definitely cannot give me any tube and say, make platelet-rich fiber. No way. You need a very hydrophilic tube surface, chemical free, and we only started realizing that by comparing these different tubes and machines. So what we did in this video here and what you saw there was that after we started learning that, I said, you know what, I think it's the tubes that are making the differences, because we're getting different size clots. And I said, draw my blood with 2 types of tubes, draw them in a random order, put them in the same machine at the same time, same angulation, same G-force, everything's the same. The only difference is the tube. And when we actually started to look at the membranes, how strong the fibrin clots were, on and on and on, there was differences. And that's when we realized how important the tubes are. I always say this, you'll find this in my textbook everywhere and in all my lectures, the tubes matter more than the centrifuges. And amazingly, you buy these tubes for anywhere from 85 cents to $1.55. And that's what actually matters a lot. And we'll get into more detail on that as well. So this was the study that we had published. It was titled A Novel Method for Evaluating and Quantifying Cell Types in Platelet-Rich Fibrin and an Intro to Horizontal Centrifugation. This is the most cited paper in the last 3 years on platelet-rich fibrin. And one of the things that we did in the study, which was very different than all tests that were previously done in PRF world. When you actually look at PRF and FDA and how they measure how concentrated this is and that, they always use the exact same test to do. They say, spin the blood, separate the layers, take out the plasma zone, and send this plasma zone, the yellow plasma layer here, is then sent for a complete blood cell count. Okay, so you do a CBC. How many platelets do we have? How many white blood cells? You know, you can test growth factors if you want as well. And how does it compare to whole blood? And they'll say, well, we generated 6 times more platelets and 3 times more leukocytes. And that's how these tests are done. But the problem with doing the test that way there is that when you look at different protocols, you know, the high-speed protocols like the original PRF, they spin so fast that some of the cells go to the bottom of the tubes, or they get concentrated all at the buffy coat zone. But when you work with a membrane like that, you don't want to use a membrane where there's only cells at the bottom. Let me go back here. You want to use the APRF protocols where they're more evenly distributed. And so when you do this technology and you do these tests the way that the FDA wants you to do the test, or the CE, you draw out the plasma, you look at this, you quantify this, and you quantify this. This might be 20, 30% better than this, okay? But it doesn't tell you the whole clinical reality of this picture, because as a dentist, when I put a PRF membrane over top of a GBR collagen membrane, let's say, I want to make sure that the whole membrane is coated with growth factors, protected with cells, on and on and on. When I spin this way here, I only have cells down here. When I spin this way, I got cells throughout my membrane. But when I look at the way the CBC does this, they say, oh, not a big difference, no problem. Okay. And that's when, you know, we did things differently. And it's the reason why we titled this a novel method for evaluating and quantifying cell types in platelet-rich fibrin. And nowadays the tests are done this way. So instead of separating these cells, taking the plasma layers and sending this to a CBC and saying, how many platelets do I have? How many leukocytes? What we did in this study, which was done for the first time, was we said, let's take this tube of blood and separate it into 10 even layers. And then I'm going to take layer 1, I'm going to send that to a CBC. I'm going to take layer 2, I'm going to send it to a CBC, layer 3, 4, 5, all the way down. Every single layer is going to be sent to a CBC. And the reason why we did this is because if I spun on a bad protocol like the PRF protocols, this top layer here, when I send just layer 1 to a CBC, you know what's going to come back? A big fat 0. No cells, no growth factors, no nothing. And that's going to make them look real bad. And if you do the testing this way instead of this way, there's no way to bullshit the system. Okay. The only disadvantage doing it this way here is that it's a lot more work, because now you got to do analysis of 10 samples. You got to spend money on 10 samples, but the amount of data you get doing it this way here is much, much, much better. So the way that we did this is we take a pipette and we take out 1 cc at a time, 1, 2, 3, 4, all the way down. You'll notice that one layer, that 5th layer, we call this layer the buffy coat zone. And on the graphs, you're going to see little arrows. This is always, as I said before, the most concentrated area. So this is one that we always have to pay attention to, that 5th layer. 6, 7, 8, 9, 10, so all the way down. So if we take the original intraspin system and we do their protocol of 2700 RPM for 12 minutes here in their system with their tubes, everything else. Okay, 1, 2, 3, 4, all the way down. You know, this protocol is so precise that when you get to that 5th zone and you're drawing it up, it doesn't even mix. So it stays exactly how you want it until you put in the tube. Using a pipette like that is a very accurate way to be able to slowly draw up every single layer all the way down to layer number 10. This is the data here. So here you see the number of leukocytes, platelets, lymphocytes, red blood cells, neutrophils, monocytes, okay? And the way that the graphs are layered, this is the average, the control. This is the top layer, 1, 2, 3, 4. 5 is the buffy coat zone, 6, 7, 8, 9, 10. So when you look at the red cells, there's obviously no red cells in the upper 4 layers. That's plasma. The 5th zone where you have the buffy coat and the transition, you start to have some red blood cells, and then the red blood cells are all pushed down. When you look at the platelets, look at this. Almost no platelets in the upper 4 layers. Lots in the 5th layer and some even in the 6th layer and down here. Look at the leukocytes. Nothing in the upper 4 layers, most in layer 5, but a lot of them down here. What happened? You spun too fast, okay? You spun so fast and you pushed all the cells down here. Why do you see more white blood cells down here than platelets? Well, the heaviest cells are the red blood cells. They go down first, then the white blood cells go down, and then lastly, the platelets. And if you keep spinning faster and faster, you're going to push more of those cells down as well. Okay, so when you see data like this, it's very clearly shown you went too fast, okay? Now, when you spin the slower speeds, the APRF, and this was work that was done by Ganazzi, you now see a more even distribution of platelets in those upper layers, okay? And the one thing that we found, and we couldn't figure it out in the beginning, but since then we figured it out, when you look at the white blood cells, you still have a lot of the white blood cells, majority of them actually in the bottom layers. And we had since learned that the reason why this happened is because you used a fixed angle centrifuge, okay? So we'll get into the reason why that happens. But between LPRF and APRF, if you have to make a decision which way you want to spin, this protocol here is a lot more effective because at least you get more of the platelets evenly distributed. Had they gone horizontal, more of these cells would have gone to the upper layer, and I'll show you the data and how that's done afterwards, okay? But between the two, like I said, this protocol here is a lot better than this one here. Okay, and this was just a summary from, what happens in our paper, just kind of explaining where these cells are going. This right here is a real life image, okay? And I'm going to explain this very, very simplistically because it's not rocket science. Out of the work that we do with osteogain and other research that we've done, this is probably some of the easiest research that we've done that is easy to understand. When you look at the size of these cells and what you're doing with the centrifuge, they're separating based on density, okay? Light cells go to the top, heavy cells go to the bottom. So when you look at a real living cell, the red blood cell is the big guy. White blood cells and red blood cells, they are almost the same size and they are almost the same weight, okay? The platelets are much smaller. So on any device, it's pretty easy to separate out platelets from these two guys because they're a lot lighter and they're a lot smaller. So a centrifuge doesn't have to be so well calibrated to accumulate a lot of platelets. To separate out white blood cells from red blood cells, that is a lot harder to do. And it takes a lot of fine tuning because they're almost the same size and they're almost the same weight. And so it takes a really fine tuned device that's optimized in order to get those cells. And why are the white blood cells so important? Well, we've learned over the years that, and different research looked at this, when you add white blood cells in regeneration, it dramatically improves the regeneration process, which is why Intraspin originally called it leukocyte and platelet-rich fibrin, or LPRF. They really wanted a lot of those white blood cells there because they understand how important they are. And they also fight with infections. So if you work in dentistry, for instance, where there's a lot of bacteria everywhere, they help with host defense and regeneration, okay? Now, logically, when you separate these cells based on density, the way that it works is that it's the difference, the G-force between the difference between the minimum of the tube and the maximum of the tube allows, and that gradient difference is what allows the lighter cells to go upwards and the heavier cells to go downwards. If this tube wasn't angled and it was just up and down, they would not separate based on density. Okay, you need some kind of difference between the min of the tube and the max of the tube. So logically, if you want to improve the efficiency of how to do that, you take that tube, and it's called a swing out bucket, and I'll show you videos. The tubes go in and up and down, and when that thing starts spinning, they're going to fly out. And the advantage of doing that is that now the difference between the G-force at the min of the tube and the max of the tube is more widespread. And so I got a bigger ability or a better ability to pull the heavy cells down and the light cells going upwards. So that's advantage number one. The bigger advantage to this system, especially with PRF or PRP, whenever you spin on a machine like this, okay, let's say you have a platelet that starts up here. When this thing starts spinning fast, the cells go outwards, okay, to the back of the walls, and then they go downwards, okay? So if you have a red blood cell, that started up here, it goes boom against the back, and then it starts going down the wall of the back tube because it's a heavy cell. If you're a light cell and you're a platelet, for instance, you start spinning fast, you're going to go poof against the back, and then you're going to start climbing up because you're a light cell. But the problem is as these platelets are going upwards on the back walls there, or the white blood cells especially, they're going upwards, you got all these big red blood cells coming down. And what happens? They get trapped, okay? A lot of these red blood cells accumulate on the back, they get trapped, and those cells don't actually make it to the upper surface. That's why when you spin on an LPRF or APRF on a fixed angle device, all of those white blood cells are typically staying down here because they can't actually make it to the top, even though they're lighter. So when you spin on a horizontal, it's not rocket science, it just makes perfect sense. When that white blood cell is starting back at the bottom here, he's no longer getting shoved against the back wall there. He's going a straight line horizontally to the upper surface. So he's just walking a straight line, and those cells, will more easily separate this way, as opposed to this white blood cell having to climb up this mountain to try and get to the top when all these cells are coming down. He's just walking a straight line across and they're not bunched up on the back walls there, okay? So people will ask, how much more efficient is this device? Around 4 times. You'll accumulate between 4 and 6 times more cells, a lot more effective, to the point where our medical doctors that teach courses in PRF, like our orthopedic surgeon and our medical doctors, they say, look, in our field, if you're going to do a knee injection into somebody and 100% of the regenerative properties are coming from platelet-rich fibrin, there is no way that anybody in this audience should be spinning on a fixed angle centrifuge. And these guys are very, very strict about it. You know, you cannot take Dr. Talek's courses and use a fixed angle device. He just doesn't allow people to do it. He's like, look, we're charging $2,000 to do a simple knee injection and the whole machine's worth $2,000, $3,000. There's no way that he allows anybody to spin on these lower concentrations, okay? In dentistry, it's not quite as big of a deal because, like I said, a lot of the regenerative properties are coming from sticky bone or from the bone graft or from whatever collagen membranes you're using, etc. I always tell people, if you're doing a lot of PRF, it's worthwhile to have a horizontal one because it will work a lot better. If you work in facial aesthetics, for me, it's a no-brainer. I mean, I would never do a case with a fixed angle centrifuge anymore now that we've seen the data with these fixed angle devices, because these ones here just work that much better. But again, just all depends on how you view your practice and what you want to do with your patients. So when we look at, you know, if people have never seen a video like this, when you look at a horizontal centrifuge, the tubes, they go in up and down, and when it spins out, they swing out horizontally, okay? And that's how we're able to separate these layers more effectively based on their density there, okay? So some advantages: number one, bigger difference between the min and the max, okay? So this is just logical. Like I said, it's not rocket science, or you don't need to be a PhD to understand this. In research labs, when we separate things based on density, we always do them horizontally, and it works a lot better for PRF as well. Okay, so that's advantage number one. When you spin on a fixed angle device, a lot of people will often see the angulations, right? It separates like this. It's not, the cells bunch up in the back here and they bunch up on this angle. So it's not a nice even distribution of cells. You always have cells on the back walls or at the bottom of the tubes. When you go horizontally, it's a clean, complete separation, and the cells are then evenly distributed throughout the whole layer, because when that tube spins horizontally, it's not on an angle where everything wants to go to the back. It's like this. So the cells are evenly distributed throughout those entire membranes, and that was work that Masakwood published back in 2020. This figure right here is the one that most other colleagues are showing in lectures. So, you know, if you go to a lecture even in Europe and somebody's been doing a lot of research in the PRF world, they often show these figures, and it's very logical. You spin on a fixed angle device, everything goes poof to the back. And now you're trying to separate these cells based on density. When everything is accumulated back here, it's not very effective. When it's horizontal and that tube goes completely horizontally, they separate nice and easily. It's very logical, right? There's a lot more space and the cells can get to the proper layers more effectively. You know, when you look at a fixed angle device, like if you look horizontal versus fixed angle and you see the angle there, this little video kind of highlights. And if you have a tube that's very hydrophilic, you know, this is actually an PRF tube from the lab that we had before, but after the spin cycle, you can see, look at the angulations there. Look at all the dots that you see in this tube. Why are all the red dots only on the back there? You don't see them on the side and you don't see them on that side. What happened? Fixed angle. You started spinning fast. What happened? All those red blood cells are getting pushed all the way to the back and they're slamming back there. And the problem is that a lot of them will actually, you know, go through death, cell death from the forces that are being applied on the back walls there. And you see all of these red blood cells bunched up all the way down. If you look in a microscope, it's not just up here, it's all the way down. And those poor little platelets and white blood cells that start down there, they're trying to get to the top there. But the problem is there's all these clumps of red blood cells everywhere and they don't actually make it to the top. They get stuck underneath these red blood cell clumps and never actually make it to the upper layers. And that's why, like I said, we've done a lot of research in this space with cells where they're going. Nobody will ever convince me that you can accumulate leukocytes, white blood cells, on a fixed angle device. Impossible, okay? And when you read even the old research articles, they've never been able to do it. The leukocytes, they get trapped in the bottom here. The only way that you can accumulate especially white blood cells, is if you use a horizontal device. Okay, so it's it's not rocket science, but it's very, very important for people that want to work in this space. If you want to understand it and do the best you can for your patients, you absolutely need to go horizontal. So after we published that first article, we had submitted a lot of grants, research grants, to organizations to get funding to do better research, to better understand where cells go when you spin. So I always say, before our group in 2020 did this research, the best paper ever published on this before this was Ganazzi's study, where he looked at 3 different protocols at 3 different G-forces. What we did was we studied from every single patient 24 protocols on a horizontal system. And we wanted to know where exactly do these cells go at different protocols, because it's not very well understood. So systematically, when you go donate blood, you can give 300 cc's of blood. So that's 30 tubes. We were taking 24 tubes from every single person and spinning from 100G for 3 minutes, 100G for 5 minutes, 8 minutes, 12 minutes, 200G, 3 minutes, 5 minutes, 8 minutes, 400G, 7, 1,000, 1,200, okay? And then we would apply different protocols, different G-forces, different times, but systematically look at where are these cells going. And I can tell you, you can look naked eye, 100G for 12 minutes. This right here looks the same as 1,000G for 3 minutes, looks the same as 200G for 8 minutes. They all look the same. But when you actually look at what cells are where, it can be totally, totally different. And that's why you really need to use systems that are properly researched, right? And this was a lot of work, like I said, from every person, 24 different protocols, each protocol 10 CBCs, every layer. We had tested over 300 samples, so it was a big, big, big job to do. And it took us many months with many researchers helping on this, but very worthwhile, because now we have protocols that make sense where the cells actually on these horizontal systems go to the upper layer, and you can see the white blood cells as well are going to the upper layers. Much, much, much improved compared to the original protocols. And that's where we're at today. And like I said, a lot of improvements have been made with respect to protocols there. So if you're interested in learning more about it, like I said, read the research articles. We provide them all free, and the company is completely transparent. On the website bioprf.com, 4 times more effective than fixed angled centrifuges. And we've done all the research for the horizontal devices that's been horizontally. So there's been a lot of improvements there. The next conference, I'm going to go through the clinical indications, just because I'm running a little bit short on time. I did want to speak specifically on tubes before the end, which will take me about 10 minutes, and then we'll get wrapped up here with questions. I said earlier, the tubes are more important than the centrifuge. And, this is something that we learned years ago. And it was very, very shocking when we learned this. Red tubes, hydrophilic, white tubes, hydrophobic. We had always been trying to build better tubes that were more hydrophilic. And I remember, when we were doing this research back in 2018, seeing differences here. This video, was one that was very, very shocking for me that this is a video from 2018 here, so about 4 years ago now. And what we were trying to figure out at this time was we were starting to understand you have to do blood draws in 90 seconds or less. And when we started to fill up these tubes, we were counting. So instead of poking somebody in a vein and saying, okay, it took 15 seconds to fill it with blood, we were just taking the butterfly needle, putting it in water, and then timing. Okay, this tube fills up in 15 seconds. This tube fills up in 20 seconds or whatever. And when we started doing back with these tubes here specifically in 2018, the PRF tubes, we were all shocked out of our minds when we saw, what was going on at that time with respect to these PRF tubes. So as we were filling them to figure out how fast they would fill with water, one of the things that we noticed, and it was only recently in 2018 and onwards, the tubes started to have chemical additives inside these tubes. And so when you see specifically these PRF tubes, they're loaded with all of these chemicals, and bubbles were forming and everything else. And I had never seen that before in my life. And unfortunately, like I said, we were telling our patients all the time. I mean, we're working in clinical practice, many, many clinicians we had trained. And now all of a sudden, I'm telling everybody there's no chemicals, PRF's all natural, on and on and on. Meanwhile, I got all these chemicals inside these tubes, which is a complete, it's completely unnecessary. And one of the things that drove me, crazy at the time was that all of the work that I had done with PRF tubes over the years from 2015, 14, all the way up to 2017, 18, you'll look here, this is an old tube that were previously single pack. November 2017, these tubes are from 2015. They always have 2-year expiration. So these are old tubes that we had in the lab that I had been using for years and years and done all the research with these tubes with Masako. And when we filled these guys here up with water, no chemicals. So even though the exact same PRF tube had no chemicals for all of these years, all of a sudden 1 year to the next, it now has all these chemicals. They're dual packed, they're made in a new facility. And like I said, causing all kinds of inflammation. And for all of the people that I was training, I remember with a periodontist in LA, he had posted on Facebook 1 year, anyone using Chacroon's PRF system have experienced any increased risk for infection or increased pain versus non-PRF use. Myself and a few other people started having problems. 170 comments here. A lot of people having issues with this. That's when Yufeng started doing a lot more work with tubes. And it wasn't until this article was published in 2019 by a Japanese group, so people that I don't know personally, evidence for contamination of silica microparticles in advanced platelet-rich fibrin matrix preparing using silica-coated plastic tubes. What these researchers were doing was they started realizing there's different chemicals in different tubes. They were spinning PRF, taking out the membranes after the spin cycle, putting them down in a petri dish, doing fibrin digestion with enzymes, so getting rid of all the fibrin, and whatever was left over, they were taking images of with SEM, and this is what was being left over, and this is what you were putting back in your patient, which is, awful. So one of the things we did with BioPRF is we said every single one of our tubes, absolutely no chemicals. Understand the technology and how to make clots better naturally with glass, and how to change and modify the glass, and how to make it more hydrophilic by changing the crystals or the surfaces, on and on and on. That was work that was done by Yufeng, and we've stayed committed for all of these years. Never, ever use a tube with chemicals inside. It's completely unwarranted and there's no need to do it, okay? The problem is a lot of these tubes are made in China. They're not very well regulated. And, unless you have somebody in China or you know what you're doing, like I said, very, very dangerous. And so since that was done, I remember being in Ganazzi's lab, we had looked at, research that he had done in 2014 with different types of tubes. All the time, the tubes were being changed. And these ones don't have any chemicals. And then all of a sudden, 1 year to the next, there's a lot of chemicals. I don't know if there's still chemicals in these tubes or not. I sure hope not. But like I said, it's something that I tell all colleagues, make sure whatever tubes you use, I don't really care. But if you're going to tell your patient it's all natural with no chemicals, make sure that there's no chemicals inside your tubes, okay? Because it will cause a little bit of inflammation and it's completely unneeded. If you don't need to use any chemicals and you've never used chemicals before all these years, there's no reason why you should add chemicals to them all of a sudden. And one simple test that you can do,
another little video just to go over.
We call this one here the water test. It's very easy to do. If you want to know if you have any chemicals inside your tubes, all you need to do, add some water to the tube, put the lid back on. You can pop the lid, give it a shake. Okay. If you don't have any chemicals, you shouldn't have any bubbles. If you grab one of these PRF tubes, and I haven't tested them recently, I hope there's no more chemicals inside. Like I said, once I saw these chemical tubes, we stopped working with this company completely. When you shake this up, if there's no chemicals, or if there is chemicals, you'll see the bubbles right away just by doing that little shake. Okay? And I recommend everybody do that. Yufeng and I had done a lot of work in this space. So this is actually Yufeng that these are all red top tubes here. A red top tube is not the same as a red top tube is not the same as a red top tube. You'll see here, look at this tube here is darker than this one, which is different than this one. And you can put different amounts of crystal. You can chemically treat the surfaces if you want. You can add chemicals inside. There's many, many different things. And clinicians need to have better knowledge in tubes. And I highly recommend you read some of the tube papers on our website, because that's what's going to decide what you're putting back in your patient. So there's a lot of work that was done in this space. And amazingly, you're buying tubes for like 85 cents to $1.35 or $1.55. And that could make a big difference in the regenerative properties and whether or not there's chemicals or not. And I'm the more I can go all natural, the better. Always. I try and avoid as many chemicals as I can in my patient always. I'm not a holistic practice, but like I said, the better we can do for our patients, like I said, that's very important to me.
Okay, perfect.
And so with Yufeng, like I said, one thing that we've done with the tubes is, you know, over the years, we've been comparing them. You'll see here 3 different types of tubes, the PRF tubes, the intraspin tubes, and the glass tubes that were developed by Yufeng. We were drawing them up here on my own arm in a random order, okay? So you'll see here, this is just a colleague that's doing a blood draw on me. She's filling 6 tubes up in a random order and then spinning for the 8-minute protocol. Okay, after the protocol is done here, I'll just start the video so you can
So
see it.
usually, of course, after the spin cycle, so take a look at this. This is the plain glass tube, okay? After the spin cycle,
Oh, you didn't even open it.
nope, 8 minutes. Okay, that's because of the tube technology. So that's whenever you change the actual design in the glass and you actually understand how the science works. That's a plain tube, right? There was nothing in this one. Expiration date. Okay, so that's where I think, you know, these things here are of course healthier than for patients. These are off-label use, of course. Okay, but again, like I said, look at that. Okay, nothing is changing. Now, if I take the intraspin, okay, it's still liquid. Okay, take a look at it. If I was to shift this, okay, of course it's going to ruin that sample. There's a clot that's there, of course, but you can tell it's not as clotted, and that's got the actual, you know, silica inside of it. That's the plain tube again. That's the other one. Okay, I can keep it upside.
Okay, so that's chemical free. That's understanding how to make glass more hydrophilic without using any chemicals. And that's something that was, you know, like I said, done a lot with Yufeng. Very, very important. Probably the most important thing you need to understand for platelet-rich fibrin technology. No reason to use chemicals in these tubes. And that's something that we stay committed to. You know, when I started flipping those tubes over and people realize that, hey, it's staying clotted and you get a nice thick clot from that, a lot of people started making images and posting them on social media. And amazingly, look, I can tell this was spun on horizontal. This is spun on fixed angle. You know, I could tell what people are using just by the images, fixed angle, horizontal. So a lot of people, you know, were messaging me or posting on Facebook. You know, I got to admit, these tubes are a game changer, incredible result compared to the obviously inferior tubes I was using. Thanks, Rick Miron, for the opportunity to try these. It really should not be me that they're thanking. It's really, you know, Yufeng Zhang, who's the researcher that I work with on this. You know, he made the big difference and the big impact. And a lot of people do cases, you know, first PRF case, nice big clots that are formed here. So when you're not sure, like I said, always perform that water test. Last thing, a lot of people are curious to know what we do with the heated and the membranes. And I wanted to show some of Dr. Michael Picos's cases. When we use the bioheat technology to make membranes, we spin at a slightly different protocol. The upper PPP layer is what we're going to heat. The buffy coat zone is what we mix back into it. So once we heat it for 10 minutes, it's now denatured albumin, and then we mix them together. That's what it looks like. It's very different than liquid PRF. This is what we inject in people's faces, what Robert Talick was injected into the spine, and what we can create membranes for. Of course, we did all this work with the FDA, and the FDA, we use ISO 10993 is what it's called. They characterize how long biomaterials are going to last. So, you know, when a collagen membrane says our membranes last, you know, 8 to 12 weeks, they take a collagen membranes, they put it underneath the skin of these animals, and every 2 weeks they do histology and see how long it lasts. When we did it in this study here with the FDA, this was PRF side. In 2 weeks, PRF's gone. This is the ALB PRF side, so the heated stuff. It's still there 4 to 6 months later. So the FDA gave it a 4 to 6 month resorption period. It does go away and get replaced over time. And so the way it works, we heat it. We then mix them together. So you guys saw Robert Talick doing all this. I'll skip over this fast to save time. And that's what we use in aesthetics. So, you know, if I was to just use liquid PRF, I could get some improvement without a doubt, but I can't, you know, put a filler into somebody. You got to heat it. And that's the biggest technology change that we have in PRF in the facial world, which we train a lot of people on how to use this technology. It's a great technology, like I said, and you know, it's been a lot of fun to work with this stuff. In dentistry for years, in 2019, I was in Switzerland, and a lot of people don't know this, but Bern is the capital of Switzerland. And so the biggest hospital in Switzerland is in the capital in Bern. And we do a lot of the trauma cases because it's a small country. And when people would come in with car accidents and fractured this, that, and their faces on and on and on, the oral maxillofacial surgeons were always using titanium meshes to reconstruct these things. But titanium has a high rate of exposure, of course, and we all know this in dentistry. So instead of just using PRF over top of titanium or collagen, we would use these PRF membranes, which lasted 4 to 6 months, which was perfect because typically we'd go back in after 7 months and remove the titanium. And this would be nice to decrease the rate of exposure. And since then we use these custom shapes so we can make whatever shape we want. And this is something that, you know, Dr. Picos was working on, which was really cool. But what this is right here, that's what the PRF membrane looks like. So what you saw, but it was made in the custom shape. So it was made right here. But this is actually sticky bone. So your regular PRF mixed with bone graft. And on the outer end of this is the extended PRF membrane that lasts 4 months. And the way that this is made is that if this is your tray, the first thing we do is we make the heated stuff. Okay, it's now been cooked. We make a layer here. So let's say if you want a membrane that's 1 millimeter in thickness, you make a layer at the bottom of the PRF membrane that's going to last 4 months. Over top of that, you add bone graft. So let's say your bone allograft, and you build up however much you want. If you want to augment your ridge 3 millimeters, you add 3 millimeters of the allograft. Then you add your liquid PRF. You wait for everything to clot. Then when you take this out, you have your sticky bone that you're used to with your PRF membrane here, your extended PRF. He will then take this and go to a defect. If this is your ridge, just go boom, right on the ridge, sticky bones on the ridge. You've already got your built-in membrane, you know, your collagen membrane, your replacement for collagen that will last 4 months and prevent soft tissue infiltration. So this is something that Dr. Picos has been teaching for the last 2 years. And, you know, every time that I give Dr. Picos a new technology, I always tell him, you know, start small and do little cases, but, you know, he does the most extreme, biggest cases. And, you know, it's amazing to see some of the work that he's doing. But, you know, I was even scared when he started using this technology on full arch zygomatic cases, you know, the most complex things he was working on. But what he's doing in these cases here is building the PRF and comparing it to, you know, fat grafting or, you know, buccal pads. I mean, he's doing all kinds of things comparing it. He's been using this technology for several years where, you know, these are very invasive procedures with zygomatic implants, and there's a lot exposed here. And of course, what he's doing is covering this with the bioheat technology here and just making whatever custom shapes, covering it up, suturing it closed. It's 100% biocompatible. It's 100% natural. There's not a single chemical. And so it, you know, it gets resorbed over time. It's very biological. So soft tissue healing occurs just like with PRF. It's great. I mean, it's a great tool to work with, and it's great to see him, you know, do these types of cases there. So it's really cool to see some of the work there. In 1 month, when we do the next lecture, we're going to cover dental indications of PRF. So you guys will look more clinically at how we use PRF precisely, where it's used effectively, not effectively. And we'll also cover some on facial aesthetics as well, because I think it's a growing field. We had the opportunity to write a book with Dr. Davies, who's a plastic surgeon, and she wrote basically the whole book. I just wrote the sections on PRF and some of the research that was done in the field. But, you know, it's a growing field, and we do a lot of these cases in our offices today, in our care aesthetic office in Jupiter. It's a great field to work in. We're allowed to do it legally, which is great in Florida. We're allowed to do anything from the neck up. So this is completely within the scope of practice of dentistry, and a lot of money in this field. It's safer. It's easier. There's less risk. I mean, it's all biological. It's good for the skin. So, you know, it is a booming field, especially where we live in Florida or California. And I'm sure in Greece or any parts of the world, there's always people that are doing Botox and fillers. So going more natural is always advantageous. You know, a lot will cover things with microneedling and how we can use PRF.
So we're just going to do a little video to go over what the bioheat looks like. So
This is a good little video here.
the patient that we're working on, I just wanted to show people what it looks like because it's very different.
This is the
in
biofiller,
consistency.
so you can see what it looks like.
When you look at it, it looks a lot more like, almost like fat tissue. Okay, and that's what we're going to inject into our patients. Either we make membranes or we can inject this as biological fillers into the skin.
So that's what I use, you know, 10, 15 times a day when I do the facial procedures, and we can inject that. That's exactly what Robert Talick is injecting in somebody's spine or people's knees. So it just lasts a lot longer than regular PRF. It looks a lot like fat tissue, in fact, and lasts about half a year. So it's great. Like I said, we, instead of doing Botox every 4 to 6 months, when people want to go more natural, we do a combination of a lot of lasers with the biofillers and with regular liquid PRF as well. So we do a series of different treatments that takes about an hour, and we charge $1,500 to do these treatments, and they're a lot of fun to do. It makes people really happy, and it's all natural, low risk, and that's how we achieve these types of results here, which are published in our textbook. Okay. If anybody wants to learn more about what we do, we have Care Aesthetics, so it's the Center for Advanced Rejuvenation Aesthetics, and been working there for quite some time now, and it is something that I created. So it is my office. I own entirely the office, and it's great to collaborate with medical doctors and orthopedic surgeons. So I hired a couple of them to come in a few days a week to do different things so that we can continue with research and write more articles in medicine and dentistry as well. I'll show this actually on the next session, just so that we can get done here. And we do a lot of, scar revision and other things. So I'll teach all the protocols on how to do this with lasers and PRF. I mean, this was a lady that had skin cancer on her nose twice and had to get 42 stitches. And when she came in and consulted, and she was like this, not looking, and we do a lot of lasers. So we use a lot of high-end lasers to treat this with PRF, and I'll show how that was done. This is her today. Like I said, it's obviously life-changing when we can do some of these things on outside of the oral cavity. And quite honestly, doing stuff like this is a lot easier than dentistry. And it's fun. So it's great if you're allowed to do it with your licenses to be able to work in these spaces. And I'll show how this is done in a month from now. And again, this is a lot to do with our collaboration with the different doctors. We also have physician assistant and nurses that work in our offices as well. So they deserve a lot of credit, but these are the 4 doctors that we do a lot of the research with on the medical side. So that's it. I'll answer the questions. If anybody ever wants to email me, this is my email address, rick@themironlab.com. And again, in 1 month from now, we'll go through all dental indications, and we'll do some facial aesthetics as well in the next one. So thank you very much. I know a lot of people stayed on for the entire time. I ran a little overtime there, but I'm happy to answer any questions now.
We actually have 3 questions. I think you can see them, but before we do that, should we launch the poll just for a minute and see what the people want to see?
I'll do both in the next session, just because I didn't get a chance to do a lot of the dental stuff, so I'll definitely show some of the stuff. Yeah.
Good. So let's go to the questions then. See.
Yeah.
You want me to read these to you, or you can read them actually?
I can read them, yeah. So the first question is, PRF used mostly for the healing of soft tissue, or does it also help in bone regeneration? That's been addressed in systematic reviews. So it is a lot better. The results are better for soft tissue. It has some improvement for bone regeneration as well, but it's more indicated in places that are more in low vascularization areas. So it's a little bit better in sinuses versus GBR. And there's a little bit more evidence for sinuses. We use it for all procedures because, like I said, with the handling and for what it costs, we'll always improve the handling of GBR procedures. So we like to use it. And if it's only minor, even if it's 5–10% improvement, like I said, it's still great for the handling properties. So that's that question there. Can you use the BioPRF system to produce PRP? Of course, right? So it's a standard centrifuge, it's horizontal. It'll be better actually if you go horizontal to produce PRP as well. But quite honestly, with the advancements that's been made in PRF, why would you ever put an anticoagulant inside a tube when you don't need to do it, right? That's the differences. And that was asked very early in the lecture. But today, like I said, we don't use PRP because we can keep liquid PRF liquid now for 4 hours. Before it was only 15 minutes, or orthopedic surgeon would say, well, if I'm going to do a knee injection, or let's say a hip or spine, I have to make sure this stays liquid for at least 1 hour. Or if you're doing, let's say, hair regeneration, it's got to stay liquid for quite some time. Today, we can keep liquid PRF for hours and hours. Another question here, dear Rick, congratulations for your work and lecture. I'd like to know what your opinion about Shyam's new publication of standardized G-force allows preparation of serum PRF qualities regardless of rotor angle. Conclusion, the present study tested the hypothesis of whether PRF components in bioactive were modified using a swing out rotor centrifuge for fixed angle when applying the same RCF and centrifugation time. The presented results confirm that the components in bioactivity of solid and liquid pure matrix are modified by the applied RCF and centrifugation time, regardless of the centrifuge rotor angle. These findings are of great importance, highlighting the sensitive role adapted in the centrifuge protocol. Thank you so much. You know, we've tested this a lot, and we have a lot of independent groups that have shown even better results than ours, so up to 6 times more, and that was published by other groups. But logically, and I've had a many conversation with Bob Marks, who actually gave me the idea to do it. When Bob Marks first invented PRP, everything was done on a horizontal centrifuge. And the reason why is because when you go from the min to the max of the tube, you can elongate the G-forces, so you can separate these cells faster and more effectively. So if you look online, you know, this is what I recommend people to do, because there'll be different groups publishing different things. You can go on Google and just type in fixed angle versus horizontal centrifuge and read about what they're both utilized for. When you have a fixed angle device, they're typically utilized for pelleting. So what you're doing is you're always separating cells outwards and downwards to the bottom of the tubes. And in a research lab, that's all we use fixed angle devices for. Horizontal devices are always used for separating cells based on density. And so, you know, different people publish different things, and, you know, I'm not too concerned about it. It's very logical. And like I said, when people read about it, and, you know, it's logical to me, you know, they understand that. So, you know, people will have differences of opinions. Is there any more questions?
I think not. If there is one, so now it's a good time to put it in the Q&A. Let's wait 10 more seconds. Actually, Rick, we don't have another question, so we'll see you on the 23rd of February again.
Yes, sir. Absolutely. Thank you for having me.
The presentation. Thank you for your time, the energy, and everything you said was very interesting. And we'll see you in about a month then.
In about a month. Yep. Sounds good. Okay.
Great. Thanks.
Have a good evening, everybody.
Thank you.
Bye-bye.
Bye, Rick.